Good morning. It is great to see you here. You are the initial the people who braved the early morning traffic, and we will have others coming in during the day. We're very excited to have the second annual Global Health Economics Colloquium, and particularly pleased that today it is not just a UCSF affair, but co-sponsored by our friends at Stanford and at UC Berkeley. We have a fabulous program, and I will not delay getting to the program, so in just a moment, but I'm sure you all have copies of it looking ahead. We've got panels on cost effectiveness, large data sets for cross-national policy analysis, workforce and workplace, assessing national policies, behavioral economics. We have a lunch, which we've allowed ample time for networking, and we'll have interest tables. And after lunch, we will review the activities at our three institutions, and then move from 3 to 4:30 to parallel workshops on challenges in implementing the Global Health 2035 agenda, which should be a lot of fun to engage on that. And we will end with a reception. So there were snacks as you came in, there's a free lunch, and there's a reception. So I don't know whether or not that meets the criterion of contradicting the economic adage, there's no such thing as a free lunch. Now I know you all had to come here to get it, but just the same. Let me also offer welcome from our co-hosts. Doug Owens from Stanford will be participating later. He couldn't be here this morning due to a scheduling conflict, and he wrote a little welcome, which I will read. On behalf of the Center for Health Policy at the Freeman Spurrier Institute for International Studies at Stanford and the Center for Primary Care and Outcomes Research in the Stanford School of Medicine, we are delighted to co-host the colloquium. We look forward to learning more about the work of our colleagues in global health. We believe that the colloquium will serve as a catalyst for building collaborative relationships that will help us all make progress on our goal to improve global health. And in addition, I want to offer the welcome from Stefano Bertozzi, who is the Dean at the School of Public Health at Berkeley, and unfortunately he can't be here today, but sends his best wishes with similar sentiments to Doug, that this is a great opportunity to collaborate and connect and pursue our collective vision for global health, and in particular with the tool of economics. So at this point when I teach, I usually say, are there any logistic questions before we dive in? But I won't, because if you have logistic questions, go outside and ask someone out there. We start with a terrific panel on cost effectiveness analysis. Stefan Vergey, I'd say actually, Kazia, will you take over from here and do the introductions? Would you like the panelists to sit there during the other talks, or wait until the end?
Probably wait till the end so they can actually see the presentations.
Okay, so in that case, Kazi, I will turn it over to you. And you can introduce yourself as well, I think, right? If you don't mind?
Not at all.
That's it.
Hi, good morning, everyone. I'm Dhruv Kazi from here at UCSF and San Francisco General Hospital. I'm a cardiologist, and I do health economics work during my research time. We have a really engaging panel this morning, and I wanted to start out with a quick background. When I was a resident in my final year of residency applying for cardiology fellowships, I told my cardiology mentor that I was going to take a year off to go to grad school to study health economics. And she and I had worked together for a couple of years, and she looked me straight in the eye and said, "Kazi, get serious now. At some point you have to get a real job." The one good thing that has come out of this toxic debate around healthcare reform is that both sides of the spectrum at least agree on the fact that costs are a problem here in the United States. In other countries where resources are far more sparse, the recognition that costs, considering costs is not just important, it's the only way forward, has long been present. Europe and Australia and our northern neighbour have incorporated costs into their regulatory processes or in their purchasing processes, and now increasingly low and middle income countries are interested in understanding what their money is buying when they invest in healthcare. We've seen an explosion in cost effectiveness papers in the literature. And you would think that because there's so much interest, the methods around costing have been figured out already. What we'll see in this morning's panel is that that's not exactly the case. We're still trying to understand the best ways to capture costs, to measure cost effectiveness. And so we have a really interesting panel here, and I hope you we'll hope the audience will engage in the Q&A that follows. So I'll start with our first speaker. Stéphane Verguet is going to talk to us about extended cost effectiveness analyses. He's assistant professor of global health at the University of Washington, has led some very interesting work in ECEAs, modifying the methods of traditional cost effectiveness to capture additional parameters related to cost and financial security. So, thank you.
How are you?
Good. Welcome.
Thanks. It's probably,
It's an apple breathing.
All right. Thanks. Good morning, everyone. Yeah, thanks very much for the invitation and the opportunity to, I guess, no, that's the wrong thing. All right. Okay. All right, let's restart. Thanks for the, I'm very excited about, being here today. Thanks for the opportunity to talk about some work where we try to develop some new methods for economic evaluation, particularly in the context of the Disease Control Priorities Project, and which is very relevant also for discussions around universal health coverage. So what I'll do is that I'll start by a bit of background, how we see that as relevant for the UHC agenda, then talk a little bit more about what we're actually doing in these extended cost effectiveness analysis, what we call ECEAs, and then try to conclude with a few remarks on how this is relevant in terms of priority setting in global health. So first, most of you I'm sure are aware there's been enormous attention in the last 5 years around universal health coverage. I mean, it's been the topic of 2 World Health Reports, 2010, 2013. You have the Director General of WHO, Margaret Chan, who says that universal health coverage stated in a speech that it's the single most powerful concept that public health has to offer. In particular, the World Health Report 2000 left us with this, famous cube, where in its 2010 report, where the idea was to highlight dimensions, 3 dimensions to consider when one is considering pathways toward universal health coverage. Briefly, to consider, what the population, who is covered, which population should be covered, what kind of services you want to expand, which services should be covered, and interestingly, what proportion of the costs should be borne by individuals as opposed to the health system. Yet, there's actually been very little guidance about how one actually moves on the cube. Now, you can, of course, you must acknowledge that every country has a very different health system. Hence, it's not that very easy to probably come up with some solutions and remedies that apply everywhere. Yet, there's been very little discussion about how to move efficiently on the cube, in the same way we purchase efficiently health benefits and so on. So we think that part of the issue, or maybe not issue, but part of the thing that we need to do is to move from what we've been doing traditionally in cost effectiveness, which is to very much focus on technical interventions, like, I name here ART for HIV/AIDS. You can think of the poly pill. A lot of cost-effectiveness analysis is very much around, drug assessments and so on. And to have a more holistic, broader perspective on the health systems, and considering the fact that when you do priority setting, there's a number of ways resources are allocated, and also multiple criteria behind or besides burden of disease costs, things like equity and impoverishment. And specifically, what we aim to do here is to build on the extensive, explosion that's very true, as was said earlier, of the cost-effectiveness literature, but to build on this and to look more specifically, in addition to what we've been doing, into two specific points, which is to look at distributional consequences, so things like equity and how things are happening among different socioeconomic groups, rural versus urban settings, but also things like different geographical areas, which are very relevant, especially if you have a federal system. And more importantly, perhaps, to look at financial risk protection and what can be the good benefits of health policies in preventing medical impoverishment. In fact, it is actually even in the statute of the NHS in the UK that one of the purpose that the NHS and a lot of the welfare healthcare systems in Western Europe was created around to prevent people from money worries, to prevent to have to worry to pay for healthcare and so on. And so one thing that, besides the distributional consequences and equity, one thing that we're interested in is to look at how health policy can buy good things that are not necessarily health outcomes, such as, preventing people from being impoverished in an efficient way. So, what do we do in practice? What we do in these analysis, and there's a few I can point you to if you're interested in the discussion. We try to look at a specific policy. So the easiest to think of is public finance. That's what funds insurance, and a lot of health insurance systems. If we think about Western Europe, for instance, are based around public finance for health insurance. But you can also think about tobacco tax. You increase taxes on tobacco, and you can also think about a range of other things around, regulating helmets for road traffic injuries and so on. Anyhow, the idea is to focus more at the policy level, some policy instruments, and then to look at basically three kinds of things. The health benefits. I mean, we're doing health, so we might as well, keep looking at health gains. That's important. So in the context of tobacco, that would be the number of premature deaths that are averted due to tax increase because people are quitting smoking. And then the specific focus we like to take is to look at household expenditures. So to actually figure it out, like how much people are spending, say in the case of tobacco, how much they're spending to pay for their cancer bills or their heart disease, and how much of that would be basically prevented because they actually quit. And then what we try to do is to quantify, these, scaling them with respect to the income of individuals, to quantify, in other words, how much, people are impacted by their healthcare bills that are out of pocket. In other words, trying to differentiate the fact that if you spend $100 on medical bills and you make $1,000, you're much more impacted than if you were making $1 million or so on. So that's what we're trying to look at here and trying to quantify the household impoverishment averted. And to do that in a systematic way for different socioeconomic groups or different geographical areas or different population subgroups. So one thing I would like to emphasize is that what I think we're interested in is to look at efficient purchase of non-health outcomes, equity, and then interestingly financial risk protection. So when you think about the cube, and I think in this afternoon we'll talk more about this, is how one can move efficiently on the cube. So I'm buying, health gains, in a cost-effective manner, but I can buy in a cost-effective manner financial risk protection. So that's one outcome that we're very interested in, is to have, how much it costs per poverty case averted, what are these benefits, and so on. So to conclude, just a few remarks on how we could use this for priority setting. And for instance, one first thing I think is this enables you to look at progressive prioritization in terms of sequencing, healthcare delivery. And this is, an analysis we did for public finance of rotavirus vaccine in India and Ethiopia, looking at $1 million spent of public funds, and to look at two things: rotavirus deaths averted and financial risk protection. So the sort of poverty cases averted here. So basically, the higher the better, and the more on the right the better. And what we have here is we display, the benefits across different socioeconomic groups, the different quintiles. And what this flags is that you can directly highlight, like in the case of Ethiopia or India, that the poorest income group, quintile number 1, disproportionately benefit the most from the public financing of rotavirus vaccination. So now, you can actually, which is probably, this is a single case, a technical or, a well-known thing, a vaccine, but one can actually look beyond this to think about how one wants to design a basic health package using both criteria of health benefits, but also financial risk protection. So this is an analysis we did for Ethiopia, where we looked at 9 interventions that would be publicly financed by the Ethiopian government, and to look at, $100,000. So this is, same graph, number of deaths averted, number of poverty cases averted per $100,000 spent. We looked at a range of things, and I'm not going to go into the details of the interventions here, but I think you can read them. And what we find is that there's things that we know, like measles vaccine, which is very cost effective, saves a lot of, lives, but actually doesn't cost much to treat, so doesn't bring much poverty cases averted. But in the meantime, we have things like hypertension treatment, which at a population level saves much less lives, but brings much more poverty cases averted. The point here being that when we design healthcare packages, we've been, I think, traditionally focusing on this right-hand side in priority setting, but we might as well consider things that, despite bringing a less, health benefits, actually have higher return on poverty alleviation. Indeed, I think that to conclude, what we've been really doing in most of the cost-effectiveness work in the priority setting is really to focus on the higher returns on health. So same thing, deaths averted, financial risk protection per incremental dollar spent, budget dollar, or so on. What we've been doing is focusing on high health benefits returns, so that right-hand side here, whether it's high financial risk protection benefits or low financial risk protection. So now I think it's obvious we're not going to be interested in investing in places where there's low health benefits and low financial risk protection. But we probably should start thinking about investing in places where there's high risk, financial risk protection, despite having low health benefit. An example, again, maybe things like HPV vaccine, which is in big discussions in several countries for obtaining Gavi funding, which might not actually bring as much DALYs, since the benefits are at 60 years old or so on, but actually prevent people from facing big cancer bills. And the last thing, which is beyond the sort of designing of the benefit package that we can do with CA, is that because we explicitly measure the dimension of poverty alleviation or impoverishment averted, we can actually compare the health sector with other sectors like education and development, and look at how basically investing in health can bring high returns in terms of development and poverty alleviation. Thank you.
All right, so that was awesome, and we're going to talk a little bit more in the discussion section that follows, but also we're going to have a workshop on how to operationalize this afternoon. So look forward to more engaging discussions about this. In the interest of time, I'm going to introduce the next two speakers, and then we'll do the discussion after. Carol Levine comes to us from the University of Washington. She is clinical associate professor and also of global health, and also senior health economist at Disease Control Priorities Project. Looking forward to hearing from her about the challenges of costing. As someone who's worked in this space, I know there are many, and I look forward to your solutions to them. and then Elliot Massé is, of course, from Health Strategies International, can best be described as partner in crime in a lot of projects locally here at UCSF. Look forward to hearing his experience with the most recent project that Jim and Elliot have been working on the cost effectiveness of the new Hep C treatment drugs. So, Carol?
Let's see, what help me? Oh, well, Jim is helping me. I want to echo Stefan's comments on how nice it is to be here today, although I was hoping for a little sunshine, because this reminds me of Seattle. And,
Actually, Jay, where are you? Probably better help from Jay.
okay.
So we already have enough.
So while they're setting up, I tried unsuccessfully to get my talk under 10 minutes, so I'm not sure who the person is that's going to give me the warning. So as I start, the more interesting stuff is at the back of my presentation, so I might rush through some of the beginning stuff, and the handouts will be available.
So which one is it?
It's Levin. Okay, great. Well, I might disappoint you, Kazi, because it takes 10 minutes just to talk about the problems. Sorry, okay, I'm not going to use that. So good morning, everyone. Let's get started. As I said, I couldn't do this in 10 minutes, so I'm going to go straight into the presentation. Interest is high in costing. It definitely is high. I'm just provided a spattering of very recent articles, some of them from the Lancet series that you may be familiar with, where they're saying what works and what does it cost, and those cost estimates have been generated by the One Health tool. Work that Colin Boyle and I participated in generating a investment case for reproductive and maternal health, also using One Health tool. Recent work on the Global Health 2035, which you can hear more about in the afternoon, as well as producers generating information on cost effectiveness for HIV/AIDS, TB, reproductive maternal child health, malaria. So interest is high among producers, and interest is high among users, some users. So let's talk about those users. There are multiple uses for cost data. So when we say costs, it is a word that has lots of definitions. Which costs? What are we talking about? They are different costs. So they're critical for priority setting, evaluating value for money as we start to think about new interventions, new technologies, introduction of new vaccines, new drugs, right? They won't go far if they haven't had an economic evaluation to support them, even as part of, early in the cycle, even as part of product development, all the way to scaling up. They're clearly used in generating the resources needed to scale up to 2035, to scale up in 5 years, to be used in advocacy. A lot of what we're seeing in publications, there are cost estimates for advocating for more resources, either at the national level or at the global level. They're used at the national level for financial planning and budgeting to, I was just at a meeting last week where Kenyan Ministry of Health, a woman working on their Kenyan strategic plan for HIV/AIDS says we don't even have some costs for interventions that we want to scale up, and yet they have to estimate their next 5-year national strategy. And of course, they're needed for improving technical efficiency. So a lot of what I'd like to do is I'm drawing on some reviews that we've done as the Disease Control Priorities Project. You may remember the 1993 Investing in Health actually stimulated scores of generations of individuals doing economic evaluation, and you referred to that. The number of economic evaluations has soared, and as you'll see, so have the cost studies. They are not always one and the same. So what we're focusing on is, well, how what is happening? Are we getting better costs? Are people paying more attention to it? Let's dive deep and see what we can learn from the literature on intervention costs. And I'm not going to go over this, but you'll see that we've completed searches for these areas. And these are all chapters in the upcoming disease control edition, the 3rd edition. So what have we learned about costs? We tried to draw the literature from mostly economic evaluations, partial or full economic evaluations, if we could have some faith in the quality of the data. So what do we get? We got thousands of articles on the first draw when kind of applying our inclusion criteria, all studies from 2000 and above. We got down to a few hundred studies, and from that we extracted unit costs in the areas of reproductive maternal child health, surgery, cardiovascular disease, and mental health. So you can see that areas that are getting a lot of attention and areas that likely need more attention. There's an increase in the number of costing studies over time, not surprisingly. What's interesting about this, just the literature from 2014 isn't fully captured here, so it's not that there's been a drop-off in it. But what's interesting about this is that if you look at the reproductive maternal child health, you can see that the majority of studies have been conducted in sub-Saharan Africa and South Asia. That's not surprising given where the funding is for this area. But shift over and look at the studies for cardiovascular and respiratory diseases, it starts to change a little bit to East Asia and South Asia. That's predominantly studies being conducted in China and India. And of course, overall, there's a growing body of literature on costs coming from low and middle income countries. That's good. So what's the problem? Well, it depends on your perspective. So the donors, we've actually heard some donors in the area of HIV/AIDS say, well, do we need more cost studies? You know, if they look at the cost studies in South Africa, they'll say, well, they're multiple cost studies. There may even be redundant. Why can't we use the data that we have? And yet, donors are also saying, well, I'm not going to scale that up, or I don't want to introduce that unless you have demonstrated to me that that's good value for money. So researchers, of course, and we'll see why in a minute, are saying, well, we actually need better data. And so for many years, the beauty of having increasing cost studies is that we have more information, but we don't necessarily have it being produced in a rigorous and methodologically sound way. There has been a movement, actually, in the last few years, moving to larger sample studies, 30 to 50 facilities per country. These are $500,000 endeavors, and it takes a long time to analyze those data. Decision makers are saying, but we need information today. You know, I need a country strategic program officer, working on HIV/AIDS, says, I need a number now, not in 3 years. And then WHO, who has provided so much guidance on collecting costs, conducting economic evaluations, very specific cost effectiveness analysis for different conditions, is saying, you know what? We need a sustainable system to support our efforts. We can't keep reinventing the wheel year after year. And so, in fact, there are recent and a new movement to try to start routinizing cost data collection. So some of the challenges are that many estimates are inadequate or mixed quality. There is a lot of heterogeneity across studies looking at the same thing. Many studies have noted, of course, there's high variability within a country, which is expected given economies of scale from urban to rural or different geographical locations. Some data just aren't there, and I'll show some examples of that. They don't typically capture full system costs or above facility, those surveillance, monitoring, and evaluation. And they really fail to capture costs in delivery strategy, platforms, and policies. There's very little, there are not validated methods for projecting from one setting to the other. So if we don't have the data we need, how do we use that data that we have to at least project for countries with similar characteristics? And there are multiple microcosting methods, top-down methods, but really there aren't good standards for collecting those data, and there certainly are not good standards that are being followed for reporting. So if people do use different methodologies, let's at least have standards for reporting these, so the people using these data can make a judgment about that. So I wanted to just show you some of the results from our work. Here's an example of variability in the costs. You can see for reproductive and maternal health costs in low and middle income countries for family planning and different abortion approaches. There's a wide range of estimates, and these are due to probably methodology, what's in, what's out in these costs. And then an example of, this is data that we collected for Ethiopia. There are about 11 unit costs that we could pull from the literature, and they really don't cover all of the kinds of interventions. In fact, we had to use what literature we had for the Ethiopia extended cost effectiveness analysis. So why does it matter? And I think Kazi got to this. On many levels it matters. One, if we're using published literature in our economic evaluations, we want to know that we can trust that these are reliable estimates that are going into our modeled studies. But countries and donors don't trust the data. They don't have the data. They don't know if they're using the correct data. And if that's the case, then maybe they're overestimating the costs in their budgets and their applications to Gavi or to the Global Fund. If they're using $400 for ART per person rather than $200, that's a waste of resources. There's no way to measure efficiency improvements over time, given the kind of whimsical nature that data are being used. And basically, donors, funders, national finance ministers don't know if they're getting good value for their money. So we're hoping for some solutions. There are a couple of, there are some great things out there. I'll mention maybe three of them. The Gates Foundation has supported development of a reference case for economic evaluation in low-resource settings. This is a set of principles. It does not address the specific methodological areas within effectiveness or cost, but fortunately, the Gates Foundation is now supporting a group to do a situation analysis for establishing a global health costing consortium that would improve the access and demand for unit costs for HIV/AIDS, TB, immunization, and it would also establish a website, like a one-stop shop, where people could go for methods, standards, and resources. So I'd like to just acknowledge Disease Control Priorities Network, my team, and other partners that have contributed to some of the thoughts behind this. Thanks.
That would be it.
When you're too far back, it doesn't pick up.
So I should stay
Just try in that.
right about here.
Range, yeah.
Great, okay. Good morning, everybody. It's my pleasure to present the work that our team has been doing with support from the California Technology Assessment Forum. I particularly want to acknowledge Harinder Chahal, who was definitely the first among equals on our team and did a lot of the heavy lifting on the analysis that I'm going to present here. Hepatitis C accounts for a substantial portion of the global burden of disease, and as you can see, this area here, North Africa, Central Asia, China, is the most effective area with prevalence exceeding 3.5% of the population. Southern Africa, large parts of Latin America, moderate prevalence of hepatitis C between 1.5 and 3.5%, and then Brazil, North America, less affected, but still a substantial public health problem. Clinically, the disease can be characterized as progressing slowly and yet, over time, inexorably causing in a large portion of people with chronic hepatitis C liver damage, cancer, and early death. Worldwide, about 170 million people are affected with chronic hepatitis C, a number which exceeds the current prevalence of HIV, although it is less lethal than HIV. This accounts for about 1/3 deaths per year. Treatment is complicated by the fact that there are 6 genotypes of the virus, and not all treatments work for all genotypes. In the United States, about 2.3 million people are affected with the disease, resulting in about 17,000 deaths per year. In this country, the disease is characterized primarily by genotype 1, which affects about 70% of those suffering from hepatitis C. Here's the good news: it's curable. And it's particularly curable now with the introduction and approval by the FDA of new combination therapies, particularly those therapies that do not require interferon or ribavirin, which is the standard care, has been the standard of care. Here are the advantages of the new treatments. They are many and important. These treatments are far less toxic. They require much reduced burden of pills, and dosing is easier. Shorter duration of treatment, 12 weeks as opposed to 48 for traditional interferon and ribavirin-based treatment. And perhaps most important, highly effective. So we're seeing clearing of the sustained virological response, i.e. call it a cure, of upwards of 90%, 95% in some cases, as opposed to something like 50% for the traditional treatments. There's only one major problem. These treatments are expensive, and they are very expensive. So on the one hand, you have high effectiveness. On the other hand, you have high costs. Sounds like nectar to a bee for somebody who's interested in cost-effectiveness analysis. So here are the research questions that we addressed in this project. Really, the focus was on the first 2. The third one was more exploratory. So we focused on understanding the cost-effectiveness of the new therapies when compared with each other, and also when compared directly with traditional therapy, that is, again, the interferon plus ribavirin-based therapies. The second question was, can you wait? Can you initiate treatment when patients have advanced to more stages of the disease? So in hepatitis C, there are fibrosis stages, which measure the extent of liver damage. Can you wait until patients have come to stage 3 or 4, or is it more cost-effective to treat everybody, whatever stage they're in, immediately? And then finally, we did an exploratory development of methods by which one might think about whether these therapies, which, whatever the cost effectiveness in rich countries, how would that cost effectiveness translate into low and middle income countries? Our methods were pretty standard and straightforward. We focused on the United States, and we chose a hypothetical treatment cohort of people age 60. We adopted a societal perspective. We modeled with Markov techniques the natural history of the disease, both for people who were successfully treated and those without treatment or who failed treatment. Of course, we included the cost of the therapy, that is the cost of the drugs, but also the healthcare costs that would accrue with or without treatment. So we were looking at the net costs, i.e. costs of therapy adjusted for difference in future medical costs. Quality of life, assessing the utility of various health states associated with the disease. And finally, efficacy of the treatments, which we derive from stage 3 clinical trials. The outcomes were cost and net cost of treatment, the quality adjusted life years gained as a result of the therapy, and of course the incremental cost effectiveness ratio, which is the difference between any 2 interventions that are being compared. It's the difference in the net cost divided by the difference in health benefits gained. Lots of uncertainty in the model, and so we subjected our results to a range of sensitivity analyses, one-way sensitivity analyses, scenario analyses, two-way sensitivity analyses, and multi-way Monte Carlo probabilistic sensitivity analyses. Among the key variables that we varied in the sensitivity analyses were the cure rates, the discontinuation rates, and we'll just say something briefly about that. One of the problems with the traditional therapies, the interferon-based therapies, is that the side effects and adverse events are so severe that a lot of people need to discontinue. Utilities, drug costs, health state costs. Results. We found that Sabosavir had a cost-effectiveness ratio of about $20,000. So in comparison with traditional therapy, and that is for a treat-all scenario. If you delay treatment, the cost-effectiveness ratio becomes even more favorable at about $16,000 per Dali. This is highly cost-effective by any criteria, and if you consider the cost-effectiveness of liver transplant, which is averted by successful therapy, we are way in the highly cost-effective realm. In comparison with interferon-based therapies, directly comparing each of the Sabosavir and other new therapies against PEG interferon, we also get highly cost-effectiveness ratios with the possible exception of this last one, which may be in the realm of no longer cost-effective. We ran one-way sensitivity analyses. No surprise here. The big determinants of the ICER were the cost of the drugs. Everything else relatively unimportant. All of these variables were varied between 50 and 150% of the base case costs, and even under the least, under assuming high drug costs, this doesn't seem to be working, oh, here we go, we're still at a ICER of about $40,000 per quality averted. The results of the Monte Carlo sensitivity analysis suggests that you very quickly, if you're willing to pay $30,000, $40,000 per quality adjusted life year, the chances of achieving cost effectiveness are extremely high. We also looked at drastically reduced drug costs. This is proportion of US costs between 1% and 10%, and the cost of care for hepatitis C related conditions also reduced between 0 and 30, not unrealistic for low income countries, and these drug reductions not unrealistic. We've been given to understand pharmaceutical companies are contemplating this kind of drastic reductions, and as you can see, there's a potential not only for very high cost effectiveness, but also cost saving. Conclusions. The new treatments are highly cost effective. Treating early is also cost effective. Results are sensitive to drug prices, no surprise there. And with large reductions in the cost of drugs, we can think about having a global program to actually eliminate hepatitis C. Access is very important. By no means do I want to convey the idea that cost effectiveness is the only thing that needs to be taken into account in formulating policy. And if hepatitis C is to be eliminated as a global priority, clearly the issue of price needs to be addressed. We have reason to believe, as I mentioned before, that this is now in the works. Thank you.
So we have 10 minutes for a panel discussion. So maybe we'll start out with Elliot, since that's where we stopped off. And Elliot, you mentioned that these are expensive drugs that appear to be cost effective, but to give folks in the audience a sense of it, the last iteration of the drug is $1,000 a pill. So we're talking about very expensive drugs. And that raises the question of affordability. So can you help tie in the idea that a safety net institution like mine that has a lot of patients with HCV may never be able to afford this drug that actually works?
Yeah, that's exactly right. I mean, this is very dramatic fact that one pill a day, which is terrific, the pill costs $1,000, as Kazi mentioned. I've never encountered such a severe divergence between affordability and cost effectiveness. And our partners at the California Technology Assistance Forum have done analysis on affordability and cost, and they're estimating that were everybody who's eligible for treatment, who would benefit from treatment, were they all to get it, the cost of the cost of insurance premiums would rise from between 0.5% and 1% for this therapy alone. So again, how it's financed, whether the drug companies are willing to make concessions is an open question. I don't have any inside knowledge on that. I do know that there are other equally effective or comparably effective drugs being introduced, and so there may be some competition which could reduce costs. It remains an unresolved issue.
We have absolutely very little history in pharmaceutical pricing that the addition of new drugs actually reduces prices. Do you think that the model that the antiretroviral therapy folks used of bulk purchasing may help bring down HCV treatment costs in low and middle income countries?
Yes.
Will it work?
Bulk purchasing may help. Activism may help. The pharmaceutical companies, it seems to me, want to stay ahead of the kind of controversy that high drug prices provoked in the case of HIV. So they want to get ahead of the curve, and in developing countries, they're talking about prices that are, as my slide showed, like 1% of US prices. So that's great from a global health point of view. It really does start to make it affordable. But people in the United States are saying, well, gee, how come it's so inexpensive for people overseas? What about us? So I don't have any insight into how these political dynamics will play out, the extent to which people will organize around pressuring, creating a political constituency for lower drug prices as happened in HIV. But I think there's a good chance that could well develop.
I want to remind the audience, if there are folks with questions, please feel free. Please come up to the podium and introduce yourself and ask questions. Oh, and there are microphones going around, so if you raise your hand, then someone will walk over to you. But this brings me, I have a quick question for Stefan while we're getting set up. So HCV seems a classic case where financial cost effectiveness and financial risk protection probably both need to be considered, because folks who develop advanced disease face lifetime disability. Traditional cost effectiveness has just kept away from distributional issues, saying, we're just talking about efficiency, equity is someone else's problem. Do you think that there is a way to combine equity and efficiency into a single number, or should we continue to use them in two axes as you presented?
Yeah, no, thanks. I've heard that. I've had that question before. I think it's a matter of taste. There's, some people like, composite indicators. If you can broaden the conversation, think about the, HDI index and so on. Our intent actually when we did the ECU is to have more of a dashboard approach and not to combine those. And to have a number of elements that policymakers could perhaps use in their decisions. Now, that being said, that doesn't exclude. Should I just? Sorry. So that doesn't exclude you from doing a composite thing. And in fact, one of the metric we've used, which we we like better in some ways is to estimate for financial risk protection a risk premium, which directly gives you a money metric value, so that actually you can do aggregation in that sense.
So we have a few questions from the audience.
I'm David Levine from Berkeley. When you were looking at cases of impoverishment averted, obviously the lowest quintile is never eligible since they're already poor, which suggests a much broader problem with the whole notion of poverty being a yes-no index. Welfare economists usually try and take some weighted value of income, so income to the poor is worth more than income to the rich, and then you don't have to use either dollars, as you did in one slide, or poverty-averted cases, which is obviously gives nonsense answers in very poor countries where tremendous people share poor. Have you thought about using some sort of composite index like that? And are you including the public costs of care? I guess those are two separate questions. Because normally if we do cost of care, we want to include that as well.
Yeah, sure. I mean, the metric that we use for estimating financial risk protection, I mean, there's huge controversies. It sounds like you've been probably working in this field, or at least is well aware.
You should have been warned. This is a fairly sophisticated audience.
No, I mean, I think it's so quick, specific answers on these slides, and I think more general stuff. So in that case, yes, in fact, actually on the Ethiopia analysis, we didn't have quintiles. We had an income distribution, but you're absolutely right. The idea with the poverty case, same story by the way, the catastrophic threshold is like, well, if you're, well, specifically for the poverty case, is that if you actually are really poor, if you're under the threshold, you cannot get poor, and that's an issue. So, well, there's a number of welfare functions that have been used by economists. I think we've used a number of metrics. Our preferred, we started to use a money metric value of insurance, which is basically the way insurance companies are estimating basic risk premium, which you use, technically speaking, you use a relative risk aversion utility function. And this is quite nice because this gives you a dollar value. So for the purpose of aggregation, this is a nice feature. It also is nice because there's a risk aversion framework and thinking behind it. And then the third feature is that it actually, you do away with a threshold, which I think is one of the biggest limitations of all these poverty assessments. The other mirror image of the poverty case thing is the catastrophic expenditure threshold and so on. Now, that being said, with all the good features, essentially mathematical and so on, of the money metric value of insurance, the huge problem that we face is that it doesn't communicate well to policymakers, and especially people in ministries of health. So then we came back and we said, well, this is a nice feature, and for maybe some more technically oriented audience that communicates well. But if actually the purpose is to perhaps make a change in policy making, we have to come back with these features, which have, I absolutely agree with you, huge limitations. And then there's others that we can come up with. And your second question, I think, was more specific about the inclusion of a public cost, I guess, in terms of just the costing of the intervention.
You had probably just as light figures at private costs, but I didn't see.
Yeah, sure. Yeah, absolutely. Very true. So, yeah, in the sort of bundling thing, yes, absolutely. So we measure, in fact, the denominator of the sort of like incremental spending is per public money spent. So yes, but that was, you're right, that was not on the different bundles, but that's implicitly in the denominator. Yeah.
Gavin?
Gavin Yemi, UCSF. I'm going to bring the sophistication level way down, way down, just because I'm not sure I entirely understand, Stefan. When you're looking at medical impoverishment here, is this basically because of out-of-pocket expenses for these costs. And so, because you said, you looked at rotavirus vaccine and said, oh, it's very cheap, so, you know, you don't avert much poverty. So what are you getting out of ECEA that you can't get by just looking at the cost of the intervention that people are paying for out of pocket and therefore, you know, falling into poverty? I don't quite get what's going on that's beyond simply saying, well, it's very expensive for you guys at your household level to be paying for this out of pocket.
Yeah, no, I'm very, you know, I'm sorry. I also I went fast on Vienna. I had some cartoons that were telling me, which I think I already went over. So sorry about this, by the way. But so yes, we're focusing on out-of-pocket payments. Which, coming back to the question of the HCV stuff, a very big thing is depending on the underlying, health system or sort of health insurance, that you have. I mean, in the U.S. it would be interesting, but presumably. A lot of people are insured, and so the cost actually out-of-pocket phase would be well diminished. So so I think I went fast on the rotavirus case. There is two things. What really drives I think the sort of financial risk protection benefits, it's really around the size of the out-of-pocket expenditures. I mean, if you spend money on a cancer treatment, it's much more expensive than if you spend on diarrhea treatment. Turns out, actually, we got some data recently on in Ethiopia, which it's much more. It's much more higher than you would think what people spend out of pocket, and especially as you include transportation costs and so on. Then I think for what the story is here is that if in a quick way is you have the out of pocket expenditures, then people have a certain income they can dispose of to actually pay for those. So depending on how that is big toward their income, basically you have more financial risk protection. Then on the other side is what you do as a government is you actually fund through public finance or so on, say in this case, a vaccination program. And so in that sense as well, vaccination, especially if you get Gavi subsidies for the new vaccines, tend to be relatively cheaper intervention. So the sort of return is actually much higher in that sense.
We could keep this discussion going for quite a bit longer, but unfortunately, or perhaps fortunately, we're going to move on to the next session. No, it's a great discussion, and but I just in the interest of keeping not too far behind schedule, thank you very much for this panel.
Thank you, everyone. And we're going to continue, as a quick reminder, we're going to continue to talk about ECEAs in one of the workshops this afternoon.
And Jenny, you want to come on up? Can you introduce yourself?
How long do you want to go?
Oh, well, your introduction and, Sanjay and Aaron and Sanjay, she's here.
Okay. It is, I think, this one, this first one. Yeah. Morning, everyone. I'm Jenny Liu, economist here at UCSF in the Global Health Sciences, and I get the honor of introducing two of our colleagues from Stanford who are doing very exciting work with large data sets and using them, squeezing all the information out of them to assess cross-national policies and programs. So I'm going to take a very quick moment to sort of set the frame by telling you an anecdote from my PhD experience, which was when it came time to figure out what I was going to do my dissertation on, I went to my advisor and said, what's the fastest way out of here? And he said, well, collecting your own data takes a lot of time and effort, and it's really hard, so you should probably use somebody else's. And that's what I did. But he didn't actually tell me how hard it was. So I have a lot of respect for people who use observational data and all the techniques and sweat that go into figuring out how to make it work to answer the questions that you want to answer. So I'm going to introduce Dr. Sanjay Basu from Stanford. He is an assistant professor of medicine And his research focus is on global development and human health, which includes the use of econometrics and simulation models to study how socioeconomic changes and social policy interventions affect primary disease risk among low-income populations. He's going to be presenting on using observational data for policy analysis. And then followed after that is Iran Ben David, also from Stanford, assistant professor of medicine. And he's going to be talking about changes in child mortality. And his larger research is focused on understanding the relationship between policies and health outcomes in developing countries, specifically with respect to the large investments that the global community has been undertaking in the recent decades. So, Dr. Sanjay Basu.
Thank you. Good morning. I'm going to be talking about a few methods that are new-ish in the sense that they've been introduced and increasingly popular over the last 2 to 3 years. And I also say ish in the sense that they're not entirely new in the sense of providing a tremendously new way of thinking about observational data. That is, they're intended to do what all observational methods sort of fundamentally try to do, which is overcome our limitation of either practically or ethically or financially not being able to do a randomized trial for some of the most interesting policy questions, or at least what I find interesting. By way of example, I'm going to use one of India's school lunch type programs. Some of you may have seen this harrowing picture from the New York Times several months ago of parents crying over their children who had died from school lunches that were prepared in containers that had previously contained fertilizer. And in the context of this example, what happened following the international reporting of this tragic but all too common type of incident was a number of analyses relating the school lunch program to adverse outcomes. So just drawing from one of many recent analyses, the school lunch program had been correlated to stunting and wasting actually increasing, which seems totally backwards from expectation, even after controlling for income differences among rural children. Now, the economists in the room might be muttering to themselves words like endogeneity and selection, and the epidemiologists might be muttering confounding by indication or omitted variable bias. But whichever language you may speak, the common theme is one of perhaps unmeasured factors, unobserved factors, or unincluded factors that might relate the meals program to this worse outcome. Just to show that this is not some pathological problem of India, here's an example from the United States of analysis relating, for instance, food stamps to increased obesity after controlling for income. Perhaps that is indeed the case. Food stamps are causing obesity. Alternatively, perhaps there are other unmeasured factors omitted from this regression. Supermarkets in the area, your childhood history that may push you towards being in situations that lead you to food stamps and also to lead you to be obese that weren't captured. So in our usual sense, in the epidemiology crowd, what do we try to do? Perhaps one of the most popular, for good reason, methods is matching, perhaps propensity score matching. The idea being, suppose we try to mimic a trial as much as possible. Get people together who are very, very similar in all the observed characteristics we can find. Age, sex, income, race, whatever we can measure. Try to make people as similar as possible between the group in the program and the group out of the program. The dilemma, although it's an extraordinary method, the dilemma is this assumption built into it called strongly ignorable treatment assignment, which is a fancy way of saying after you took all the observable factors into consideration, nothing else should be pushing people into the program or not. And for some of the programs that we're really interested in evaluating, that would be a very hard assumption to support. The idea that after you take into account age, sex, race, income, all the measured factors, there's nothing else that you have unmeasured that is different between the people who enter the program and those who don't. The economists in the room may prefer another technique of instrumental variable analysis. Those unfamiliar, I think of an instrument as a push. It's something that is random in the environment that pushes you into the program or not. For instance, in the food stamp literature, people often use the instrument of whether or not it's very easy to enroll in the program because different states, by historical coincidence, contracted different private companies to make the software for which you enroll in the food stamp program. And it turns out that the most expensive software, as it were, is not the best. Surprise, surprise. So you could end up in the food stamp line for 30 minutes in some states like Utah. In California, you might end up sitting there for 6 hours because the software is rebooting. This is a kind of encouragement into the program or not. The similar person in Utah versus California might give up in line. And so the dilemma with an instrument, among the many assumptions needed to be fulfilled, is that the instrument is encouraging you or not to be related to your outcome only by virtue of the program. So the software is only related to obesity by virtue of whether or not it's pushing you into the food stamp program. Another dilemma is the problem of weak instruments. You can think of this as trying to mimic a trial again, but you have very poor adherence in your trial. Some of the people in the placebo group are moving over to the treatment group and vice versa. That's a weak instrument. It's not really fully randomizing people. My colleague Mike Baiocchi has been working on a very interesting method known as near-farm matching, which tries to mimic the benefits of both of these approaches. And given our time, what I'm going to do is give you the intuition behind these methods and then refer you to a few papers where you might be able to experiment. The idea is to match people as closely possible on their observable characteristics, like propensity score or other matching, and then make them near on those characteristics very far apart on the instrumental variable. I'm a 32-year-old Indian man. You find another 32-year-old Indian man in another state, and we are very far apart in terms of whether or not our food stamp program has efficient enrollment. Near on observed, far on our instrument. The idea is that it actually makes the weak instruments quite a bit stronger and gives one more power in the inference. And I chose these examples in part because one actually finds reversal of the effect direction when implementing some of these measures. We did it for the India program, and a colleague did it in the context of the US food stamp program. One sees very tightening of the intervals in the context of near-farm matching. It has the same disadvantages, though, of any other instrumental variable-dependent approach. That is, it requires inference on those people who can be pushed or pulled. If you're so desperate that you're going to sit in line for 6 hours for food stamps no matter what, this is not the inference for you. You're looking at those marginal people who can be pushed or pulled. The locally treatment effect, in other words. It also reduces your sample size. You're throwing away people who can't be matched. In the context of this dilemma, I also want to allude to the fact that much of this discussion is interesting because it talks about population level inference. At a population level, we often care about things that are metrics of, for example, inequality, that are not just the sum of the parts of individuals' experiences. Here, for example, is our data from India on 29 villages we've been following since 1980. One village in red decided to implement a sanitation program specifically targeted not to see if it would reduce diarrhea, but actually the degree of inequality in the village, because the targeting was the intervention being tested. Normally, one would do a so-called difference in difference analysis, find some control village, assume the two have the same trajectory over time, and compare them. The dilemma is, in many cases, you don't have a good control village. And an example here is California. You often do many policies in California where you couldn't possibly rationalize comparing it to another state because California is strange. The example of this method, synthetic control, the intuition is one looks at the underlying factors driving the outcome. For example, in this case of diarrhea, there's a number of variables, coliform bacterial content in wells and so forth, that one knows as predictors of the outcome. You then weight your possible available control groups. So if you're comparing intervention in California, look at Utah, Arizona, weight the populations that have similar predictors of the outcome. If your outcome is tobacco smoking, for instance, look at the number of adolescents, the tax rates, and so forth. And you create a synthetic California, to compare against your intervention. You then do a so-called placebo analysis, where you do that for each other possible control group, and then look at whether your intervention state is sufficiently different from the others. Finally, one of the dilemmas with this approach, though, at population level, is that it leads to ecological fallacy. You would want, in theory, to build up from your individual data up to the population level. A very classic technique in economics is decomposition, which says not only how much does my intervention explain differences between groups, but how much does one group benefit more than another. Education, for example, each year might help one person more than another in different groups. The dilemma with decomposition classically has very strong assumptions, very strong parametric assumptions. And so finally, after many years of work, we've worked out a method in which you can relax those into a non-parametric form. For example, disparities in hypertension are really at the right tail of the hypertension distribution. In the National Salt Reduction Program, when you decompose who benefits from each gram of reduced salt, is really impacting at those at the higher levels of the hypertension realm. So, in the interest of time, if you're interested more in the assumptions behind these methods, their derivation, and their potential use, I'll refer you to these papers, and happy to chat more later. Thanks.
Thank you, everyone. It's nice to be here. I thought that Jenny's introduction, she was going to say that the fastest way to get out of her PhD was actually to go and be a mentee of Sanjay Basu, because he's the way of running forward with methods. That's certainly one way of moving well around here. Thank you, everyone. It's nice to be here. My name is Aran Ben David. I'm going to try to take the sort of the data aspect of this session and talk about large data set in applications in global health, and so I'm not going to focus so much on methods. From my intro slides, you can tell two things. One is that I'm at Stanford. The other one is that I don't listen because I didn't use the same template as what Jim had asked of me, and so I'm going to try to keep to 10 minutes, but you know, the precedents are bad. Okay, so I'm going to start from 4 stylized facts. I'm going to talk about distributional effects and child mortality. I'm going to start from 4 stylized facts. One is that mortality, there's a big mortality gradient related to wealth, whether you're talking about between countries. This is low-income countries have lower life expectancy, high-income countries have higher life expectancy. Or within countries, this is a slide from the famous Whitehall study that talks about the differences in mortality based on your station in the workplace. However, the overall mortality in low and middle income countries has been declining. In fact, it's been approaching the mortality in high income countries. So in that sense, there's been some convergence between countries. Wealth, however, has not been wealth inequality has not been declining, and so this is the Gini index, which measures the concentration of wealth. And whether you're talking about high-income countries or low-income countries, it's been stable or even possibly slightly increasing. So that sort of leads to questions, some intuitive questions about what is happening to the distribution of child mortality within countries. So the overall child mortality in low-income countries has been declining, but that can be consistent either with a convergent picture between the wealthier and poor, or with a divergence. If one looks at the big data sets, such as the global burden of disease, you can't really tell what is happening to child mortality based on wealth. And so we looked at that, and so here I'm going to go on a slight tangent. That's really actually the focus of this talk, and it's talk about some large data sets, and I'm going to focus on the demographic and health surveys. Demographic and health surveys, for those of you who are not familiar with them, have started back in the late 70s or early 80s as a result of a lot of concerns about our lack of knowledge and understanding about fertility in populations in developing countries. They've been an enormous source of data. There are now well over 300 data sets that are at the individual level that are publicly available. In fact, if you're quick, you could potentially have them down on your laptop by the end of my discussion. Depending on the bandwidth, I suppose. And they provide information not only on basic aspects such as fertility and mortality, but also on things like HIV status, malaria status, hemoglobin, height, weight, health spending, health behaviors, and all of these are available, publicly available, made or partly because they're sponsored by the USAID. Each one of these surveys costs in the order of several millions. It's an incredible resource, mostly largely underutilized. One can use it to map different aspects. This is taking the DHS data for Africa and mapping it at the district level for each country for metrics such as urbanization or electrification of different regions. Again, you can sort of see that those, the dark purple and on the left and right seem to mostly match in shading. And so we're going to look at the mortality gradient for wealth, and what we did is create a wealth index, and we take the wealth, the available household possessions, and create a wealth index in 54 low and middle income countries between 2002 and 2012, and really categorize them into three bins, because that's going to make it sufficiently diverse, but also you can sort of see you can observe a gradient. We're gonna create from the primary data in these 54 countries a metric of mortality on about 2 million children. Okay, this is all sort of something that can be done. It's pretty straightforward, and look at the trends by mortality, by wealth group, and look at the mortality trends over the past 20 years. Okay, and we're going to measure whether mortality has been converging or diverging within countries. Okay, I'm going to look at two different measures of convergence or divergence, I suppose. You can look at that. So, for example, one can imagine that. So the one is going to be the absolute difference between the rich and poor, and the other one's going to be the ratio between the poor and rich. And you can imagine that, for example, on the left-hand side, the delta, the absolute difference is it doesn't change, but the ratio is actually increasing, which would not be fully consistent with a convergence picture. And on the other hand, on the right-hand side, the ratio is staying the same, even if the absolute difference is getting smaller. And again, that wouldn't necessarily be consistent with convergence. But these are the two measures I'm going to look at. Okay, well, this is what it sort of looks like. So each dot represents the mortality rate in each country, in each wealth stratum. Okay, so the left-hand series of dots in each year are the poorest, and in the middle, and then the wealthiest in blue on the right-hand side in each series. And when you look at the sort of the best fit curves of what is going on with mortality, you can see that things are really converging. And they're converging whether you're looking at the difference in mortality, and they're converging whether you're looking at the ratio of mortality, and they're converging in almost all countries. And I'll show you a little bit more about that. And there are a couple of things that are sort of interesting and nice to note about this. Really what is happening is that under 5 mortality among the poorest has declined the most, sort of quite rapidly. In fact, really there is hardly anywhere where under mortality is above, or under 5 mortality is above 200, even among the poorest. We're really watching this sort of the tail of the epidemiologic transition, where you have sort of very high mortality among children. and that's slowly disappearing. And the other thing that's sort of interesting to note is that there is no clear evidence of convergence until about 2000, and then really after that there's sort of evidence of really accelerating convergence. Sorry. I mentioned that not all countries have had this pattern does not hold for all countries. In fact, for about 25% of countries, there is no clear evidence of convergence, and this is looking at the ratio between the poor and rich, the ratio of mortality between the poor and rich at the beginning and at the end of when I sort of measured them, you can see that in some places like Honduras, Cambodia, Ukraine, things have not been converging. Okay, and so one thing we wanted to see was can we tell even at a very basic level what seems to be correlating with that, and so we looked at the correlates of where things are converging and where things are not converging, and so we looked at the ratio at the beginning and the ratio at the end, the difference between the two. We wanted to see where things are converging among the poorest relative to the wealthiest. Okay, so the correlates, gross domestic whether a country has had is doing well on their GDP is not a correlate. Fertility rate is not a correlate. Public health spending as a percent of GDP is not a correlate. HIV prevalence, not a correlate. What is a correlate? Are governance measures. Okay, government effectiveness. These are the worldwide governance indicators, and I can talk more about them. But they essentially measure perceptions of how well the government functions as a measure of the sort of overall institutional capability and capacity in countries. So I'll just close with just a few sort of really open questions about why is child mortality gap between the poor and rich closing? Well, there's no clear explanation here, but one suggestion is that there's a rapid decline among the poorest, and so there's something that's preferentially benefiting the poor. What are the implications of this governance issue to convergence? Potentially, one can say, well, even for the basic convergence, you need fundamental governance and institutions in order to enable public health policies, even for the sort of simple, potentially inexpensive interventions that could benefit the poorest. With this, I'll end. I'm happy to talk some more, and happy to take questions, I think, with Sanjay.
Do you guys want to take a seat at the table? So, fantastic. Thank you both. I'm well aware that this is supposed to be a very lively discussion, so let's just immediately open it up to the floor. And I see a tall hand in the back.
My hand is full, is it? Aaron and Sanjay, amazing, really.
The kind of work you do makes the kind of work we do possible. We rely on amazing work like yours. Can I just ask you, Aaron, I mean, it's kind of spectacular. That year 2000 inflection happens to be the year that, we adopted the Millennium Development Goals. Can you go into the DHS data and look at coverage of interventions to see whether what you have found can be correlated with increased coverage rates of, evidence-based interventions in the poor, or is that not possible?
There is so much that's possible in DHS. So, you can, here are just a few examples of things. You can see whether bed nets are at home, whether they're being used. You can see, there's evidence, there's actually a record of the vaccination card of little children. So it's, the actual signatures of the vaccination cards are available, and so you can see exactly about vaccination coverage. There's HIV medications are available in DHS. There's a ton that's available, and you can certainly try to correlate those. Some have.
Stefan? And then the woman in the back.
Yeah, no, thanks very much. It's really nice work, both of you. I have a couple of quick questions to Aaron. I think kind of like what Gavin was getting at, we were just actually chatting with Julia. Did you look at contextual Because I think maybe I've looked quickly. Do you look at contextual things like, socioeconomic development, education, also, and then related to your metric, you looked at ratio and deltas. Have you? I'm sure you've looked at other things. Which ones were those? And have you perhaps looked at rates of decline? That could be an interesting. You could compare the upper and the lower and look at if there's convergence based on rates of decline.
So let me see if I can remember those. So one is about the different ratios. So the answer is yes. The reason why we sort of selected those in the end is really to make things pretty simple and transparent and easy to replicate and understand. The second thing about sort of contextual factors. I mean, my sense, and this is my hypothesis based on just my hypothesis, is that a lot of the rapid decline among the poorest really has been about sort of increasing public health coverage of very effective and relatively simple technologies that are easy to implement, and that's my sense. I'm sure that things like education have contributed. I haven't looked at literacy rates specifically, although there would be sort of an interesting correlate.
Mark Lackey, is this the right way to do it? I have the title here is about large data sets, and in this whole arena where people talking about big data and everything like that, the question always comes up to me is like, well, how good is it in the first place? And I'm looking at some of the data set that you analyzed, and just could you comment on how reliable these things are and whether cross-national or over time differences make any of this stuff impossible to analyze?
Yeah, so it's a good question. One aspect that's so a few things about DHS. One is it's the same questionnaire. It's the same core survey has been around and been implemented since the early 1980s. The very same questions, same. If it's not in English, they translate. In terms of the quality of the survey, it's really pretty high quality. They provide all the survey sampling errors and whatnot. There is a question about the quality of there's a question about whether, for example, countries where again, roads are better. It's easier to sort of get to remote villages. Surveyors are potentially paid more. Maybe they have no PDAs and whatnot. Whether the quality of the data generating process changes by country and changes over time. And the answer is probably yes. Now there are lots of data in DHS that's. It's about hemoglobin tests, and so things like that are a little bit more. You can sort of have some faith in those a little bit more over time.
Thank you. Can we have the woman in the back, please, ma'am?
Hi. Yeah, there. My name is Safa.
Yeah, we can hear you.
Just speak up.
Here we go. No, we won't pick you up.
Okay, Safa Abdallah. No, it's.
So it's Safa Abdallah from Stanford. Thank you very much for the great presentations. My question is for Aaron. Two questions actually are for Aaron. One of them just echoes the last question, especially for the wealth index, because since the 70s, the questions wouldn't be the same. They would be asking about internet. The late 2000s, that wouldn't be there, and it doesn't necessarily have to be the same question as long as it's harmonized, as long as it's measuring the construct of wealth and poverty. So how confident can you be that? Because that was a very long-standing problem with doing this kind of work. And the second question is about the role. Do you see any value for bringing in international aid and the role of international aid in this picture?
To the second question, I would say maybe. Although again, it's a whole topic of conversation. On wealth, it's a great question. There's lots of sort of different gradients that people try to use for for a variety of health metrics. One thing I would say is what we have done, what we have tried to do is use the same household assets that are asked in every survey in every time in every country. The type of floor, the type of roof, the water source, the availability of a car. So that wealth index is harmonized across all countries and being used, and just really to define the relatives within country, but it's the same index.
Yes, the gentleman back.
Dan Robbins, I'm a pediatrician and a bit of an interloper. I'm not attached to an institution. We implement HIV prevention programs in children in Zimbabwe. I was just interested in, you had finding 3 about governance, which I think certainly on some levels in Zimbabwe there's good governance, i.e. within the Ministry of Health, but Zimbabwe is also kind of renowned for lack of governance on many levels during that same time frame. Just the practical realities of what that represents and where is the governance level that's relevant. I think the subtleties of that are very important. And also HIV prevalence has to, it's just being someone that's actually been implementing there for 15 years, starting at such a high level, and we've gone from 60,000 deaths per year in children due to HIV to, we think, below 5,000 this year. And certainly starting at that high prevalence and what that represented socially and being able to affect that change. Obviously the metrics and child mortality have been huge based on that. Just that the practical applications of that seem more subtle and complex, I guess, but it was a very interesting point. And you thought about how those metrics, I guess, when I look at that slide, I go, well, that seems kind of right, but it just, for other reasons, then would it immediately be apparent, I guess is what I'm saying.
Right, and in some sense, this is sort of an interesting observation that again sort of requires more sort of more in-depth look. Basically, the worldwide governance indicators are a series of it's a time series, and it relies a lot on perceptions, and so people who are outside of Zimbabwe will answer. Sort of the neighboring will answer things about, can you start? How is it to start a new enterprise in Zimbabwe? How good is the government at regulating? How much corruption? So these are the kinds of things. I'm happy to sort of go into greater detail. We can discuss this afterwards. But but by and large, these indicators have been used really pretty extensively in political science. They tend to correlate with things that you would think they should correlate with.
Sanjay, I'm going to ask a question which may be unfair. First of all, thank you very much for these incredibly interesting methods, and I was struck by your report that when applying these methods, the effect size, the direction reversed. Do you have any sense for how many studies out there, accepted wisdom on programs, could be reversed if we started going back and applying more sophisticated methods?
Not making me popular. I don't, but my boss, John Ioannidis, has done some pretty interesting meta-analyses in which he goes back to primary data in order to try to replicate them. And the number of unreplicable findings is high, which may not be surprising. The number of findings which are replicable is also high, but then when applying approaches that try to do fairer comparisons, or what I might call fairer comparisons, there's a tremendous amount of bias. What's interesting is where the bias is. So for example, we were talking a lot about cost effectiveness. During a certain time period of his analysis, one saw for certain pharmaceutical written cost effectiveness analyses a profound non-Gaussian distribution of the final cost effectiveness estimate, such that everything was just barely below $50,000 per quality, suggesting that the input parameters were perhaps adjusted a little. So I think this kind of stuff does go on. My general sense, though, is that methods evolve all the time. I think the central dilemma is always going to be whether the question is a good one and whether the data are really good for that question. So these are sort of, hammers, and we need to make sure we're driving the nails in the right place.
So I'm sensing that we have still a lot of burning questions, but I'm getting the time's up sign several times. So I invite you to do as I will do in the break period, is to ask all your hard questions for our panelists in this last session as well as the first session, and enjoy the coffee and snacks outside. What time are we coming back?
Let's aim for 10:30. We'll get a little bit closer to on schedule. And thank you, Jenny, very much.
Thank you.
I like your thought on the density.
Great stuff.
Nice to see you. Thanks for the great stuff. I'm sorry for this. There's this weird transportation program that we found that is responsible for delivering, at least within on the convention, the delivery based on the contracts. It's sort of a semi-random by virtue of political.
So it's a time series, and so it's essentially I look at the sort of the ratio year by year as the dependent variable, and then the GDP. So in some sense it's a change, but it's like it's the time series. It's like are countries that are actually where GDP is sort of going up faster, are they converging? So does this correlate to the national development? No, and that's been shown again and again. GDP is not a good predictor of changing GDP is not a good predictor of changing health. So it's the level difference is there, right? Like the cross-sectional stuff, but when you look at the evolution over time, it doesn't. Well, so I tell you, so I think the gap as a historical relic, it happened because the Industrial Revolution and whatnot, right? But what's driving health improvements now are the diffusion of technologies of simple technologies of bed nets and vaccines and clean water and public health. That's my sense. And you see like what happened in China, right? Like, so as an example, China, life expectancy and mortality went way down. Life expectancy went way up before their big jump in GDP. They made huge health improvements, and then GDP sort of followed. In some sense, if you try to do the correlation, it would look like health improvements led to their economic progress, right? And so they're sort of asynchronous. Yes, exactly.
Sir, how are you? Good to see you.
How are you?
I was going to say that there's no politically correct way of saying this, but the presentation's just pretty awesome. Convergence is something that I never quite philosophically and I want you to help me understand that, which is what is it? As long as everybody, when we talk about convergence, to countries where the decline rates are slower, but convergence is greater than saying,
so, right.
It's up again. This next panel involves the word work, and you'll hear more about that. And I'm very pleased that Colin Boyle, Deputy Director for Global Health Sciences here at UCSF, will lead the panel.
Yeah. Thanks, everyone. Thanks for coming back from the break. We always worry about that. So I'm glad this audience is motivated to come back. As Jim said, this is about work. And health economics has a very direct link to work and the interrelationships between work, workforce productivity, labor force development, and the flip side, the type of workers we need to support an economy and have effective health systems are all very important topics in health economics. And we have two speakers who will address different components of this relationship between health and work in their presentations. First, I'd like to introduce Richard Scheffler. Richard is over at the School of Public Health at Berkeley, where he is a distinguished professor for health economics and public policy. He has worked extensively on the issue of workforce development and modeling, and also on a number of other topics, which we will probably get into in the panel. And then after Richard's presentation, I will call up Susan Meffert. Susan is an assistant professor in the School of Medicine here at UCSF. She's in the Department of Psychiatry, and she'll be speaking about global mental health, a critical epidemic that has direct impact on workforce productivity, and is very much a neglected topic in the world, and one which I think is an important area where health economists can contribute. I'm also proud to say that Susan's one of the Global Health Sciences Burke Family Scholars, and so we're happy to have that association with Susan. So with that, let me invite Richard up.
Well, great. Good morning, everyone. I'm really pleased to be here and feel lucky to have found the building, which was not easy for someone from Berkeley, but
That's how we beat out the speakers.
once inside, it's a nice place, and I hope you enjoy your new home here. We have very old, ratty buildings most of the time in Berkeley, particularly the School of Public Health, which is kind of an erector set being held up by outside iron beams, if you've been there recently. So it is kind of refreshing to see a new, nice, spiffy place here. So a lot of old friends here in the room, and I'm happy to see you all and some former students, particularly Tom Hall. Where's Tom? So I learned all of this from Tom Hall at my North Carolina days going back, I don't know, 4 decades maybe, something like that, more or less. And others, but Tom I picked out because he knows a huge amount about this particular topic of health workforce and has been doing it actually longer than I. So what I'm going to try to do in my 20 minutes, do I have 20 minutes? 10 minutes? 5 minutes? 2 minutes? No, 10 minutes or so, more or less, is to make you an expert on how to do workforce analysis in 10 minutes or less. So this is a bit of a challenge. But I'm going to be talking to you about a study that I just finished with some colleagues, which we did for the World Bank. And my co-conspirator, where's Jenny? Jenny Liu, and so she knows a lot about this. She's a former graduate of our program at Berkeley, got her PhD, and she did all the hard work on the numbers you're about to see and cranked them and did all the metrics. So if you want to actually know the details, you have someone who can really help out. And she also helped me put this slide presentation together. So with that, I'll jump into trying to make you an expert. So there are basically 3 themes going on now, I think, in the global area. One of them, of course, is the Lancet Commission, and Dean is here. Dean, are you in the room? No, he's here. Anyhow, he's around somewhere.
He's coming in.
Okay. There he is. Hi, Dean. We were waiting for you to get started, so he's back there. So Dean, these are the 3 themes out there, and Dean's Lancet report with others, Larry Summers and other colleagues here on our panel chair, talks about the grand convergence, and this is an important element. I put it there because there's lots of things, but one of the things that the grand convergence means is to try to have maternal and child survival. It's about kids in low and middle income countries equal those found in middle and upper income countries. Remember that, because the workforce model I'm about to show you keys on that variable. And that's one of the reasons it keys on it, and a lot of people key on that variable. The other major theme around the globe is universal health coverage. Everybody's now into trying to come up with their version of Obamacare. hopefully a better job than that, but in China, India, all around the world, to have people covered for insurance and be able to access care. And of course, I feel that 1 and 2 won't happen without 3. And 3 is having enough healthcare workers. So you're not going to get, you can have insurance, but if there aren't enough healthcare workers, it's not going to matter. And you're not going to get this grand convergence unless you have an adequate supply. So this is what this is all keyed on. So this is a little bit of economics. Don't get too scared. I'm not going to do a lot of it. So this, does this thing work? No, it doesn't.
Yeah, I think this one probably works best.
That works better, okay. So I'm going to do this rather quickly. You don't have to follow the details, but if you do economics, this is the wage of a worker, this is the number of workers, and you have supply and demand, and where they equal each other, the scissor here says how much you're going to pay your healthcare workers, and this tells you the number of healthcare workers you're able to employ. So this is standard textbook 101 economics. So this is called the economic model for workforce. Then there's a line out here called need. It has nothing to do with economics. It just says these are the number of healthcare workers we need. In this case, nurses, call it E. This is the number of healthcare workers that the economy in your country can afford to pay. And so the need for healthcare workers, E obviously, is bigger than NB. And these are the two models out there. There's the need model and there's the economic model. A lot of the work so far of WHO and others has been this need analysis, which has nothing to do with economics. But you see, if you have these, you can also have this need line over here. It's possible for the needs for healthcare workers to be less than the economy can afford to pay them. And if you have that, of course, you train a lot of unemployed health workers, or health workers that leave your country. So these two concepts are quite important, they're quite different. So I'm going to try to run through them both in this 10 minutes or less exercise. Okay, so basically what we're doing is forecasting for now. The project for the bank is to 2030. So you have the supply of healthcare workers, the black line, and then you have the demand and need. So you can see in this case, the need is here. In this case, the demand would be higher than the need. In this case, the demand would be lower than the need. So this is a forecasting model over time, and I'll be showing you the exact numbers that we came up with in this exercise. And right now, the World Bank is working with WHO to try to look at these numbers and see what they might do with them. So we use a lot of data. I'm just going to leave this in the slides, but these are the places you can find this kind of data you need. You can see most of it is accessible, but not all. So on supply, I'm not going to spend a lot of time on this, but we had to put together numbers on trends in healthcare workers. And we started with physicians. We used some growth rates. The reason you use physicians when you're doing forecasts is not because they're the most important part of the health workforce, but the data is the best. And so then you use midwives and figure that out afterwards. So moving on, the need criteria is from the International Labor Organization, says you ought to have 3.45 health workers per 100,000. And the idea is to achieve this 80% coverage of births by a skilled birth attendant. I'll skip over the next one because I'm short on time. So this is basically how you do it. So visualize a bunch of data points here, which are countries, say 100 of them. And here you have the number of healthcare workers per 1,000. And here you have the births attended by a skilled health worker. right? And so when you have all these data points and you fit a curve, it looks like this. And so someone arbitrarily says the need goal is to have 80% of the births attended by a healthcare worker. You can make up any number you want. You could have said 70%, 90%. But a committee gets together at WHO and says 80%. Once you read over there, you go down and you find out you need about 2.2 health workers per 1,000. It's as simple as that. So now you're an expert on need-based analysis. Nothing more to it. We expanded it, of course. You could do this with others as well: measles, neonatal, DBT. And so the curves basically look like this, and this is what an economist would expect: diminishing returns. The more healthcare workers, the less you get. So you get the kind of flat of the curve, and you could pick any of these and just read down and get the number of healthcare workers you need. Okay. So when you do that, you can get numbers like this, and I'll do this quickly. This is all healthcare workers, and this is the median number of the ratio of physicians to nurses and midwives, and so you can figure out the number of physicians you need and healthcare workers. Now the economic model, and this is a real stylized version of it, and this is where Jenny did all the hard work. 157 countries for 23 years. We forecast the number of doctors using the GDP of the country with a 3-year lag, health expenditure of the country with a 5-year lag, and out-of-pocket payments with a 5-year lag. So what you know about workforce is when spending happens or the economy goes up, there's a lag before the workforce catches up, the demand catches up. So when we check the lag space, it takes a shock in income. It takes 3 years later for the demand to show up for a healthcare worker. If spending goes up in healthcare, it takes 5 years. And out-of-pocket is actually negative, because the more that spending out of your pocket, the less the demand is, because that curtails demand when people actually have to go into their own pocket and pay for it. So this again is what the econometrics look like. This is an elasticity. This says if you have a 10% increase in per capita income of a country, you would get an increased demand for healthcare workers of 1.7%. 10% increase in income, 1.7% increase in healthcare workers. For spending, it would be a 2.4%. With, remember here, a 5-year lag. And out-of-pocket, for a 10% increase in out-of-pocket, healthcare worker demand would go down 1.5%. So we have this for the entire world. This is every country in the world. Imagine that, a model. So we built a model for the whole world. Time's up. I'm not done yet, however. Well, thank you. So what you can see here, but I'm close to being done. Just a lot of numbers. Jim was correct to suggest that I focus on some. So for the world, the forecast by 2030 on demand is 7.3 million healthcare workers. The need-based analysis using the ILO, which is the number of healthcare workers you need for universal coverage, is 5 million. Yeah. And then WHO criteria. So these are different need-based numbers, right? But the demand is high. But the real takeaway that's interesting from this, if you take one country out of this macro model of the world, demand for healthcare workers, China, the demand for healthcare workers that you need goes from 7 million to less than 1 million. So the storyline is the economic demand for healthcare workers is essentially coming from China in the next 20 years. It's a huge driver, and universal coverage and the growth of the economy. So that is a big deal. And it doesn't affect, of course, the need based on all of that. So that's one of the big takeaway storylines. So Thank you very much. You're now experts in how to do workforce analysis.
Stage up here after. Sure. Susan, if I can invite you up to give your talk on mental health. Let me figure out how to do this. Thanks. Sit here. Should be a list of them. Oh, there you are. There you are. Sorry. Great. And there you go.
Thank you for having me. I'm daunting to follow Richard Scheffler, but I will give, as I mentioned to Jim and Colin, what is probably more of an inspirational and aspirational and utilitarian perspective on this, because this is work that I'm going to describe more the need for and the knowledge gaps than the data that we currently have. So my name, as Colin mentioned, is Susan Mefford. I'm an assistant professor in the Department of Psychiatry at UCSF. I've been here since I came in 2003 as an intern for training. And my program of research focuses on developing scalable treatments for mental disorders among adults in low-resource settings. So my orientation toward economic analyses is a very utilitarian one. There is a 75% treatment gap, which I'll be returning to, 75% treatment gap for mental disorders in low and middle income countries. That means that 75% of people with serious mental illness living in low and middle income countries never receive any treatment at all. That's not just not enough treatment, no treatment. That's an incredible statistic. And so the focus of my research is developing treatments that can be scaled up through implementation science and persuading policymakers to make the changes they need to make. Central to that is our economic arguments, and so that is my practical and utilitarian take on it. I'll be highlighting the research gaps that I think are most important for addressing that issue. So I'll start off just with some background on the problem of global mental disorders. I'm usually the only one in the room who does this work, so I always want to make sure that people have the background that they need to understand the significance of the issue. I'm sure you all know the Global Burden of Disease study. This was critical for launching the field of global mental health back in the mid-90s. They introduced the concept of the DALYs, disability-adjusted life years, one of the first broadly used measures of disability, and that was critical for revealing the huge impact of mental disorders in low and middle income countries, contrary to prior understandings. So the DALYs are composed of the years of life lost to a condition plus the years of life spent disabled by the condition. Mental disorders are typically not fatal, so their primary contribution is through the years of life spent disabled. And that contribution is enormous. In fact, they're the leading cause of years of life spent disabled in the world. This is this is from the Global Burden of Disease study, all diseases, and YLDs on the y-axis, age on the x-axis. A couple of things that I want to point out here. First, look at the shape of mental disorders, that light green. It's the only one that has this really big bubble just in the middle of highly reproductive years, young adulthood and middle adulthood. Then look over on the y-axis. We see that the peak of mental disorders for the global representation reaches about 35 million. Compare that to this slide, where we see that the peak reaches at about 30 million if we take out high-income countries, which is to say that the absolute lion's share, the vast, vast majority of mental health disability is in low and middle-income countries. Again, the bubble in low and middle-income countries for young adults and middle-aged adults, which should have their highest economic productivity. So when I say mental disorders, what am I talking about? This is nothing exotic. This is not raging psychosis. This is garden variety depression and anxiety. Depression accounts for 40% of the DALYs attributable to mental disorders from the 2010 study, and about 15% comes from anxiety. The rest is alcohol, drugs, and schizophrenia. And the global burden of mental disorders is increasing, went up almost 38% between 1990 and 2010. So this slide for me is both galling and very galvanizing, and I think it should be to most people in global health. We have known for decades and decades and decades how to very effectively treat depression and anxiety, and we can do it through many different ways and in very low-cost ways. And yet, the burden of mental disorders continues to increase. So what we really need are, what this tells us is that we must be working harder in implementation science, making the economic arguments that will be persuasive, changing policymakers' minds, and economic arguments are critical to that. This is just a quick forest view before we dive in of the economics. This amazing statistic from the World Economic Forum in 2011, mental illness will account for greater than 50% of the global economic burden from non-communicable disease in the next 20 years. As you know, NCDs are now a major focus with accepting Ebola, which turned our agenda down a little bit. And then United States. This is an interesting slide from NIMH showing that mental disorders is among the top 5 most costly conditions in terms of direct costs of treatment. It's likely because of the prevalence, and it's increasing. But a unique thing about mental disorders is that they have extremely high indirect costs. So if we combine the directs and the indirects, the cost per year is not 57 like we see over on the left on the graph, but more like 300 billion. So why is that? It's driven primarily by depression. Depression has an amazing effect on productivity, primarily through its impact on absenteeism, meaning that people miss work when they're depressed. This is an interesting chart that shows productivity loss in the past 7 days. It's a combination of both absenteeism and what they call presenteeism, which is essentially impairment. And if they look, and on the x-axis is the PHQ-9 score, that's a measure of depression symptoms. So 7 to 9, that first column, is a low PHQ-9 score indicating mild depression. And you can see we already have 30% impairment at that low level. The key thing to notice here is that there's a dose effect. So as depression symptoms go up, the percent impairment, the percent productivity loss goes down, all the way up to above 50% with severe depression. So what are the costs of untreated depression? Well, we all know that things like sedentary lifestyle, smoking, high cholesterol, high blood pressure are associated with healthcare risks. But I don't think very many people know that depression actually exceeds all of those in terms of its contribution to medical costs. It's an extreme, and that is because, largely because, that depression is associated with many physical disorders. For example, the connection between depression and cardiovascular disease has been investigated. There is a strong association between worse cardiovascular outcomes and depression. They have not completely understood the mechanisms, but their idea is that it is related to immunological function, and that's true for many other disorders as well. So the bottom line here, if you're thinking like a company, is that depressed employees are less productive and they're more expensive in terms of healthcare costs. So the next obvious question, if you're thinking like a company, is, well, what do we do about this? If we increase the mental health coverage, does that yield a net positive return? That is, if we are able to treat and reverse the depression, does the gain that we get as a result of doing that in productivity and reduction in healthcare costs offset the amount that we pay for mental health treatment? This has been done only in the US, these analyses, and only in a kind of a corporation model. This is a cost-benefit analysis, so not enough of these done yet. But to date, the 2 RCTs that have been done have shown net positive returns. But as we said earlier, the vast proportion of, largest proportion of mental disorders lie in low and middle income countries, and we do not have the data we need, these cost-benefit analyses there. There was a nice article, meta-analysis by Crick Lund recently in The Lancet, where he looked at He looked at the association between mental health interventions, including those for depression, and improvements in general economic outcomes, and he found a positive association. But we remain with this very important knowledge gap. We need cost-benefit analyses of mental health treatment in low and middle-income countries. So in terms of future directions and our hope to contribute to this, filling this knowledge gap on some level, is an upcoming RCT that we have in Kenya with a population that has very acute mental health care needs, HIV-positive women affected by gender-based violence, which is not nearly as obscure as it might sound. In fact, that's a huge population in sub-Saharan Africa where the majority of HIV-positive women lie. And we'll be doing longitudinal measures of cost, productivity, and income with GHIM's assistance and Harsha's collaboration. And we'll also be measuring outcomes in terms of HIV health and gender-based violence re-victimization, both of which have very high associated medical costs. So I'll pause, I'll stop here. Acknowledgements certainly go to the Global Health Sciences Burke Award, which is the reason why I was ever able to join the faculty here, and things took off from there. And then also the Family Care Education and Services Program with Craig Cohn, which is where this work in Kenya is based. Thank you.
Great. So we have, I think, microphones going around, and if there are questions for our panelists, yeah, Nancy, can we start with you? Yeah, wait for the microphone. Thanks.
My question is for the last speaker. That was very fascinating. I'm really curious about surveillance, especially in lower income countries. So, I think there's at least two components to that. One is the accuracy of diagnosis and how uniform that is in different countries, and the second is reporting. My hypothesis would be that mental health issues are vastly underreported in lower income countries, and I wondered what you thought about all that.
So do you mean that in the context of surveys that are going out and asking about mental health symptoms?
Yeah, I mean, I guess the other thing is I don't know where you get the data for that, and how where does that? I mean, are you getting it from DHS? I mean, I'm just, and how accurate it is, and so on.
So the Global Burden of Disease Study has its own methodology. I believe for most of these disorders, they're using something from the WHO called the CDI, the Composite International Diagnostic Questionnaire, where they can, and then they use other data where they can as well. You're right to point out this issue of cross-cultural, for lack of a better word, diagnosis of mental disorders. This issue was actually kicked off probably about 20 years ago by Arthur Kleinman, who pointed out that in Taiwan, the syndrome, the collection of symptoms that we call depression here, does not exist. And that was a very important contribution, and he really founded the field of medical anthropology on that. But the problem is that as people have gone forward, there's been kind of a pendulum swing where people have really moved initially to a radical relativism view, where there were people like Derek Summerfield arguing that people from high-income countries should not be diagnosing anything or treating anything outside of their own high-income countries. That existed for a while, and then there were the universalists who argued that we were all the same and all the diagnoses were the same. So, as you know, as with most things, we have kind of come back to an equilibrium where there's, in my work and in other people who do treatment research, there's certainly a period of ethnographic research to look at what are the local symptoms, to adapt your measures. So we do use measures that are used universally, like the PTSD scale or the depression scale. We adapt them, and honestly, that usually means adding or deleting one question or two questions. It's minimal, and that's consistent with other people's experience. And our results, if you look at the treatment that is used in low and middle income countries versus here, are very, very similar. The same types of modalities are affected.
Interesting. Thank you.
Sure.
Thanks. Right here.
I have a question for Susan. Given the burden of disease in the low and middle income countries that you said, I'm wondering if you could take what Richard was saying about workforce and comment on who's supposed to be diagnosing and treating and doing this, and how's that happen in those countries, and do we just need more psychiatrists, or what is the idea that you would use to address this?
Yeah, exactly. I should have mentioned that in the RCT and the ones that we've done in other settings. We work with Darfur refugees and Sichuan earthquake survivors. We always use local community members to do this, and this is not a new model. You can actually train people to deliver fairly sophisticated psychotherapies, brief evidence-based psychotherapies. We're not talking about laying on the couch, in a very, very effective manner. So we use people with no mental health care training whatsoever, usually community members, and in this case, in our RCT, we're going to be using healthcare, community healthcare workers, so certainly people who don't have advanced health training. When we have them available, we use them, but we can do it as we did with Darfur refugees, just with community members. So you're right, that's it. We've been dealing with that from day one. There's one psychiatrist for every 500,000 in Kenya. So.
I think we have Kazi and then Julia.
Dr. Sheffer, that was a really fascinating discussion. And I wonder, so I did part of my training in India. And if you look at cardiologists in India, if you're in urban India, you'll find one at every corner. And then you will go thousands of miles before you find someone in rural India. And so my first question to you is country the right unit of measurement when you're talking about healthcare needs? Because I worry that there are large differences that are buried in there. And the second is, by assuming that the curve holds across incomes and over time, are we making the assumption that there's no changes in efficiency, so that if other countries want to achieve the same outcomes, they have to employ more healthcare workers? Are there opportunities for task shifting or technology that may mean that you can achieve the same with fewer workers?
Well, two amazingly good questions. The first one has me say that the global workforce shortage that we find around the world essentially is in rural areas. In almost any country in an urban area, there's not a shortage of healthcare workers. So though I showed it that was actually by income level, we have all the numbers country by country. And basically you know that it's in rural areas. And so rural healthcare needs are different than urban healthcare needs, you're quite right. And in another chapter, some analysis, we actually can account for that. So, but excellent question. I think people forget that. But the global workforce shortage is in rural areas and countries. Second one about productivity and task shifting, of course, we didn't assume any of that in this analysis. And of course, so in one of the simulations that Jenny and I did, we said, what happens if productivity goes up 1%, 2%, 3%? So you can assume some numbers of productivity increases and then put them in and see how it affects the shortage. The question is how to get that productivity. And so some people don't like the word caste shifting because it means doctors get rid of the things they don't like. But it really is looking at what you're competent to do and trying to get healthcare workers to perform at their highest levels, and I think there's a lot of that. In this analysis, we look at ratios of community healthcare workers to nurses to doctors, and I didn't get a chance in my 11 minutes to go through all of that, but you're quite right. And so the question you want to ask a country that has a given budget, almost so much they can spend for healthcare workers, is do you want the maximum productivity for the same budget? If you're willing to live with 10% less doctors, I can give you 50% more healthcare workers. And that's a pretty good deal for the same budget. So all of that is in the analysis. Yeah.
Hi, I'm Julia Walsh. I'm from Berkeley.
Hi, Julia.
Hi, Richard. Great to see you. Well, I really enjoyed your, my question is, your presentation. My question is a follow-up to Sanjay's, that there has been this tremendous increase in effort in digital health technology to increase productivity of doctors and to shift not just to community health workers, but in fact to self-management. I would say between now and 2030, we are going to see some real introduction of many of these digital technologies, even in a place like China. Which will, and I'm delighted to see to hear that you have put this in with some sensitivity analysis or modeling with the increasing in productivity. But is there other ways to kind of think about this, or model this?
Yeah, I think that's much more complicated than macro data on countries is going to allow us to deal with. But of the 7 million healthcare workers that I estimated, and as I said, this work is done for the World Bank, and they'll be using it. You'll be seeing it out in reports in the next year. 5 of the 7 million is for non-physicians. So the demand for healthcare workers isn't really about doctors globally, it's about other healthcare workers. And, it sort of reminds me of what a healthcare worker is. Some people at WHO think of healthcare workers as anybody who works in healthcare. So it could be a secretary, it could be an accountant, it could be someone who does digital work, and so that's a different number. The numbers we're dealing with are just health professionals. But what you're talking about is, for that to work, you're going to need workers, not necessarily who are trained in medicine, but know the technology and how to do that. And then, so that's another level of analysis that I think we ought to be doing, because if we don't have those people trained, that's not going to happen, Julia. So it's another workforce problem.
I think we have one last question over here.
I think this is more a comment than a question, but it seems to me, I'm Craig Van Dyke in psychiatry, and it seems to me, the area I know best, mental health, that one of the big issues is the way we train people. And so in much of the world, including the United States, medical training doesn't reflect the burden of disease in the population. And so we just done a study in India, or in Nepal actually, where they get a lot, general practitioners get primary care docs, and primary care workers get a lot of mental health, and they have no idea what it is. They have no idea what to do with it. And so, as you can imagine, they're not very productive. And so it seems to me one of the neglected areas in this is the way we train people. And if we could focus on training medical students, nursing students, et cetera, at least in some ways it reflects the burden of disease, maybe we could address some of these treatment gaps.
Would you guys like to comment on that?
I guess I would just thank you so much, Craig. Craig was my chair for a long time. I would just build on that and say that I think we're so lucky to have Eric Goosby's recent return here to UCSF because I think he provides a real model for how to scale up care for stigmatized conditions in low resource settings, and did it beautifully with HIV. And one of the things we can build on is how to integrate mental health care, for another stigmatized condition, into things like the HIV care platforms in sub-Saharan Africa, which is one of the things we're doing now. But I think you're spot on that we have to be integrating, and that's something that even now, even the really top-notch studies that have been done for mental health treatment intervention have been primarily vertical, which is just completely wrong. We have to be integrating with primary care or HIV care, whatever is the priority care system. I agree.
Thanks. With that, I think we're going to wrap up this panel, and I catch up a little bit on timing. So, do you want to introduce the next? First of all, thank you. Please join me in thanking our speakers.
I'm just such a fan.
Nice job.
Thank you.
So our next panel will be on the topic of assessing national policies, and we're very pleased to have Leslie Wilson, who is an economist here at UCSF, to moderate the panel. Thank you, Leslie. And I'm going to see if I can find the next presentation.
Great. Well, I think all the panel speakers have been so great so far, and so I want to introduce this panel 4, which is talking about assessing national policies. We know that economics is often used to help change or have some effect on policy, and that's a big importance. And we're lucky here to have 2 speakers. One from UC Berkeley, Tae-Wei Hu, and hello. And he's going to talk about policies in tobacco control in China. And then following up, we'll have Marcela Alsan, who will talk about immunization policies in Turkey and how economics affects that. We'll start off with Tae-Wei Hu. He's a professor emeritus of health economics at the School of Public Health at UC Berkeley. His area of expertise is in the econometrics of healthcare research and tobacco control. He has multiple awards from American Public Health Association and also the WHO. And he's a consultant in healthcare finance reform and economics and tobacco control to the World Bank, and senior policy advisor to the Ministry of Health in China, Hong Kong, and Taiwan. So we'll start off with you. Welcome.
Thank you. I need to learn how to use this. Oh, okay. All right. So I'm glad to be here. The time is limited. I got only 10 minutes, so I got to be short. I have 23 slides. I have to skip a lot of them. So the key point is that this is a session on economics and health, but also doing the econometrics analysis and so on. So this is the topic we're talking about, the health, but also in economics. As you see the 10 years of quotation from Director General, that the health, not economic argument, the reason for tobacco control, but it's a challenge of obstacles to do the tobacco control. So to do that, what we need to do is to lay out the framework to see what kind of research evidence we can provide to address the obstacles. So you can see that I'm going to use only 2 minutes or less than 2 minutes. Talk about framework, what we're going to do this. First, we want to look at the impact of the economics, such as the raising the tax, on the impact on the smoking, consumption, and quitting behavior, and how that affects on the productivity and the health. Now, each of the box here requires a lot of papers, a lot of data, and do the analysis. And the second one, we also have to look into the equity issue, the poverty issue in relating to that. Also a lot of box there, a lot of research papers. And third one, we have to look at like a cost-benefit analysis. So say what happened if we raise the tax impact to the industry, because Chinese government owns the tobacco company, it's a monopoly. So we have to address what's the impact to the tobacco industry and tobacco farming. So this requires a lot of collaborators, more than a dozen collaborators. Here we have 2, Professor Haiyun Sun at the UCSF and Dr. Tintin Yao. So we have faculty at the UC Davis, the UCLA, of course in China, CDC, Fudan University, Sichuan University, many of the colleges. So I'm going to put into 20 years of work within 10 minutes. Okay, now, so this is the seriousness of the smoking. This is the March issue of Economist. They dedicated one special issue on the problem of smoking in China. You can see the smoking kills 100 million people in China. Actually, it's 1.2 million right now. So the question is, we have a 1.3 billion population, 300 million smokers. We have a secondhand smokers, 740 million. So in other words, 1.2 billion people about essentially exposed by the smoking exposure there. So I'm going to skip all these cost issue, skip the tobacco industry issue. I just want to show you the diagram, how much of contribution to that. So this is also borrowed from The Economist. You can see the revenue, the tobacco industry, the barrier to tobacco control, because At 2012, they have about 800 billion revenue, including profit, tax and profit. So right now it's about 1 trillion in Chinese currency. That means about 160 billion US dollars a year. So that's, you see, why is it so difficult to do the tobacco control? So, but on the other hand, the Chinese have a relatively low tobacco tax rate. If you compare to the retail price, about 45%. The WHO recommendation is about 70%. The median of tax rate around the country about 67%. By the way, the United States is not very high either. United States only about 45%. Okay, so now there's a major treaty that contributed by WHO. It's called FCTC. It's a Framework Convention on Tobacco Control. So it was ratified. This treaty has 6 provisions. One is raising the tax. The others are looking at the secondhand smoke, warning label, and also the trade issue. So this actually, China signed this treaty and ratified it in 2005. So this treaty, essentially, we, as economists, we can divide it into 2 parts. One is we call it price control, which is raising the tax. In economics, we call it move along the demand curve, or just raise the price, reduce the consumption, just Richard's chart, demand curve. Right? The second is called non-price control, secondhand smoke, no smoke in the fireplace. We call it is the shift of demand curve. We hope the demand curve will move downward with the same price level. So, but we think that the price is the most cost effectiveness analysis. So we wanted to do is that to see how we can raise the tax as compared to other non-price control as a relative impact on the tobacco control. So this is this study we published in BMJ early this year. David Levy at Georgetown and Andrew Morin at Columbia. So what we did is based on the econometric model and look at assumptions to see that using the male data. With the data we have smoking prevalence rate about 52%, 2010. So if nothing happened, of course that there's a downward trend of smoking. Maybe by 2020 it will be 50.4. Yeah. But if we're going to raise the tax in China, raise the tax to 75%, we will see that the smoking prevalence rate will be reduced to 45%, which means the change will reduce by 5.3%. We also do the simulation of the other kind of the smoking prevention kind of policy instrument. So this you can see there are some comprehensive smoking-free law is also effective, but less than the 5.3. And there is some also of the smoking ban, marketing ban, others. So this is the simulation. We show that if we do that by 2020, if we do all that, the smoking implementation of this will will save life about 12 million people, 10 to 12 million people. But on the other hand, you see that in China, because of Chinese government, they want to keep the market share. So therefore, they have not raised the price of the cigarette. On the other hand, the Chinese economy has been growing. Each year they grew about 9%, recently 7.4%. So if you look into the income plus price, then the affordability means that it's much cheaper now because price is not being increased. So if you compare to 2012 to year 2000, the cigarette is more affordable by 70%. So obviously we know that we should raise the tax, right? So the point to do that, we want to simulate a model based on the demand elasticity. We have, with High-End's help and with other Tintin's help, we have a number of papers, including literature survey. We try to, the price elasticity of demand for cigarette ranges between minus 0.15, which means they raise 10% of the price, reduce consumption by 1.5%. This is the low end. This is the conservative end. The high end could be by minus 0.5, which means they raise the price of 10%, consumption reduced by 5%. But within that, we can have a conservative estimate. If it's a 0.25% of that, 0.25% is because of the price increase, they quit smoking. Now, when you quit smoking, that means we'll save your life, right? You continue to smoke, you only reduce consumption. So we have done the econometric modeling to show that if we just use the current data, raise the 1 renminbi, which is about 15 cents per pack. The raise tax would be increased from 45% to 51%. And government revenue would be increased by 85.4 billion. We obviously, our audience is the government, so we have to make sure that the leaders of governments know that it's going to be win-win policy. So, and if we simulated about $2, the two renminbi, which will increase about 146 billion. We also talk about health issue. So in the model you see earlier, we have simulated a lot of numbers in terms of, not only in terms of the reduction of medical expenditures and increase of government revenue, but also we look at the number of smokers who will quit. So the 4 million people will quit smoking in China. And that means we'll save 1 million lives. So if we increase 2, the tax rate will increase to 58%. So that means save even more life. So what we have done is we wanted to show a policy, given what the current Chinese government policy. You know that in tax there are two kinds of policy. One called excise tax, which is a tax on the commodity by unit. The other called ad valorem tax, which is a tax by the percentage of price. China has both tax systems. So we need to look into this policy, and our very modest proposal, which was that if we raise 1 renminbi per pack, and we also want to simplify the tax system, instead of a 2-tier, 3-tier, we want to use the highest, the current level, 56%, and we also raise 5% at the wholesale price, the tax rate. We estimate about the 60%. If we do all that, the tax rate will be increased from 45% to 60%, which will be essentially about saving $2 million people down the road. So this is the example that we want to show from research to policy recommendation, but we also have to learn how we can use policy recommendation evidence to communicate with the leaders, the policymakers. That takes patience, that takes the network. And so the good news was that 3 weeks ago I was in China, and I say now is a good time, prime time, because we hear the leaders in China, President Xi Jinping, that already said he understands that smoking is not good for the population or health in China. So our policy has been requested by his office, the President's Policy Office, 2 weeks ago. And and we also talked to the Ministry of Finance, and from other sources there. This is one of the proposals among the 5 they are considering. So let's hope next year, 2015, will be the year of raising tax in cigarette in China. Thank you.
Switch to a different presentation.
Okay. That's great. That's an example of economics affecting policy right hot off the press, so that's wonderful. Our next speaker is going to be Marcella Alsan. She is the assistant professor of medicine. She's a physician economist, which is always helpful, on faculty at Center for Health Policy and Primary Health Outcomes at Stanford Medical School. She also has her PhD in economics from Harvard and an MPH from Harvard School of Public Health. Her research focuses on the causes and consequences of infectious disease, primarily for health and productivity. And she explores the interaction between infectious disease, human capital, and economic performance. So welcome to you.
Thank you. Thanks very much. It's a real pleasure to be here. This is the third paper in my dissertation, and it's with regards to evaluating the 1985 Turkish National Immunization Campaign. So I'll use the abbreviation TNIC for this campaign from time to time. So I was interested in this question because it was a large-scale campaign, and it was early enough in terms of there had been enough time elapsed. It occurred in 1985 that allowed us to look at things not only on the health dimension, but also in terms of human capital. And by that I mean literacy and educational attainment. And it was a policy-relevant intervention at scale. So particularly for mortality, a lot of times when it's a small, even it can be a fairly large cluster randomized trial, we might not be able to see improvements in survivorship and disability because we're underpowered, essentially. The other benefit of looking at it through econometrics is that one can look at spillover effects. And in particular, what I mean by that is it's not just the children who were direct recipients of the vaccine campaign that might be beneficiaries of it. It might also have affected other older siblings in the household that were not age eligible for the vaccination. I'd like to tell you a little bit about how the vaccine was rolled out and why it came to be. So it was a historical circumstance. Jim Grant, who is very famous in terms of global health and pediatrics, and Turgut Özal, who's very famous in terms of understanding the recent political history of Turkey, they had actually been friends since the 1960s. Grant worked at the USAID, and Özal was part of the State Planning Association. They both got new jobs. Grant became head of UNICEF in 1980, and Özal became the Prime Minister of Turkey, later on the President of Turkey. And around this time, there was a lot of discussion about having a successful national immunization program, and they decided that Turkey would be the perfect test case for UNICEF to kind of showcase its ability to deliver vaccinations at scale. So the way the campaign occurred was it occurred in 3 10-day rounds of mass vaccination. And it's interesting to think about, this campaign, at least for me as an infectious disease clinician and as an economist, the way that it was carried out was actually fascinating and really successful. So in this era of mistrust, they actually worked alongside the religious authorities. And so, in fact, so they had a cry ring out from 54,000 mosques. Mothers were encouraged by imams to vaccinate their children. They actually had the president himself vaccinate a baby boy and baby girl on national television. And then they had all children who were less than 16 months, estimated to be about 5.1 million, were to receive 3 doses of DPT oral polio, and kids who were at least 9 months were able to receive a measles vaccination as well. And so here's just a picture of the president and premier leading the campaign. And they had these events with lots of music, and here's these men of religion were asked to help, and they did, in large number they did. So by any measure, and what I have available is a lot of these UNICEF reports, it was highly successful. They imported 41 million doses of vaccine. They distributed almost 30 million of those. They had 45,000 vaccination stations. All of these were aimed at being between a 10 to 15 minute walk from home, including in the rural areas, and they used schools, mosques, businesses for distribution as well. Over 4 million children received at least 1 dose, and they continued to immunize after the campaign, though the effort was lower. But you can see these dramatic increases in the pre versus post amount of coverage this is for DPT and oral polio, and here's for measles and well. So tremendous jumps in coverage. So this kind of goes back to the prior speakers, Sanjay and Aran, talking about data sources. So there is a source online known as IPIMS, which is run out of the University of Minnesota, which has Turkish censi available. I'll also be using the Turkish Demographic and Health Surveys, mortality statistics, which Many of these are available through Princeton's Population Center and then Turkish statistical indicators. And I have yet to, I apologize, Richard, have yet to incorporate all the data on nurses and physicians as of yet. But what we can see just in the time series is that if your birth year was in 1985, if this is not the birth year, this is actually the regular year, what we see is this very epidemic nature of vaccine preventable diseases that occur, and then we see sort of this dramatic drop that occurs in the aftermath of the campaign. But what we do not see, and it has to do with when you actually back out what the prevalence of vaccine preventable illness is based on the mortality figures, is that we see that infant mortality rates and child mortality rates were already on this really strong downward trend. And therefore, what we don't see is this clean trend break in either infant mortality or child mortality. And if you look at what the children are dying from, it's that they're dying from diarrhea and pneumonia and things, not necessarily measles, although it does have that epidemic nature. It just wasn't a prime killer of children in Turkey at that time. But what do you see in terms of the proportion that are disabled? Okay, now here's the word birth year. So you can see that the children who were born in 1980 and 1985, these are the children that are eligible between 0 and 16 months, you see these large drops in disability. And similarly, for literacy, you see large gains. Now, this is a phenomenon we see quite often. It kind of goes back to Mark's question on the quality of the data. We see a lot of heaping. So illiterate people tend to actually say that they're born on a 0 or a 5. And so what you can see sometimes is you can see dips. But even correcting for that, taking that out with your fixed effects, or trying to use a moving average, you'll still get these pretty large increases in literacy that correspond to declines in disability. Now, I took out the equations because I think I took out most of them as per the suggestions. But basically, it is the strategy, the econometric strategy that we're going to be using is a fixed effects type of estimator along the lines of what Sanjay was talking about earlier. You know, the challenge here is that you have a treatment that affects the entire country at the same time. So you're going to sort of use the interaction of the baseline prevalence of vaccine preventable illness along with fixed effects for province and time and then the event itself, the timing of the actual event, is sort of driving the exogeneity. And these findings that you get out of this more torturous econometrics actually just reinforce the graphical intuition in that you don't see large and any significant decline really in infant mortality or child mortality. That's including if you do quantile regression. But you do see gains in literacy. So if your VPD, your vaccine preventable illness prevalence, was higher by 5 per thousand, that is implied a 10% increase in percentage point increase in literacy, and the declines in disability are about 1 percentage point decline. Now, this is something that we didn't, so this one did make it up here, but what you want to see, and this is really important for when you're looking at these sorts of difference in estimators, is you want to see that these trends did not antedate the actual implementation of the campaign. And so what you'd like to see is kind of what you see here, which is this big jump in literacy that occurs after the intervention is rolled out and not before. So, but what I said and what I really like about this paper is that we can start looking at what are the effects on children that weren't immediately treated. For example, the siblings. And so what I have here is 3 columns. First, the full sample of older siblings, then the girls, and then the boy siblings. And what we see is if you go to, if you went from a family where there were 0 children who are age eligible for the vaccine, where the entire sibling set was age eligible for the vaccine, you'd see an increase in, for the same prevalence at baseline in the community, you'd see an increase in literacy of about 2.7 percentage points among the full sample of siblings. And if you actually break that out for girls versus boys, we see that there's about a 1 percentage point difference in the stronger effect for older girl siblings than older boy siblings. And what that might be due to is the fact that if you actually have younger siblings, it actually kind of reduces the probability that you are going to be literate, and that effect is also actually more than double for girls than it is for boys. And the final thing that, because we're a global health group here, the final indicator, probably the most important indicator for whether or not a child is literate in lots of parts of the developing world is whether their mom is literate. And that effect, too, is much stronger for the girls than the boys in this particular context. All right, so in conclusion, this paper looked at used a fixed effects estimator to understand the impact of a large-scale immunization campaign. There were some surprising results for me, but there were also some nice results in terms of it did seem to affect morbidity and human capital. It was particularly important for older girl siblings. And oftentimes in economics, we tend to pick up on negative unintended consequences of public health or other interventions. And this was kind of definitely not a goal of the program, but did seem to be like a positive unintended consequence.
Good. And maybe both of you can join at the table, and we'll have open it up to questions from the audience. Thank you.
How are you?
Okay, any questions for either of these? Oh, there you go.
I just, sorry. Yeah, I just had one.
My question was, Professor, I was interested in the slide that showed the estimated impact of the different interventions on smoking. So taxation had the greatest, and then workplace bans had less, and so on. Did you take into account the possibility that there could be interactive effects and particularly synergistic effects? That the prices go up, but also I noticed that my friends aren't smoking, and that could have a combined effect that's greater than...
Sure, that's a very important question. I think we did not show the another slide. So the slide has shows the individual effect. And there's a combined effect, because obviously each individual is not mutually exclusive. And that's something. So that effect together, I think that the effect together will be about 12 million instead of otherwise. Yeah. Thank you.
Yes, here.
Yeah, again, also on tobacco. So you mentioned that the tax in the U.S. had not increased 45%, and yet I'm not a smoker, but I know that the tax for cigarettes are quite high in the U.S., and they also use, a lot of these other mechanisms. So I'm just wondering, what was at work in the U.S. to reduce smoking, if not the high tax rate?
Well, there are experts here, like Wendy, the other can talk about the U.S. tax. But my understanding is following, because United States, there's two kind of tax. One is the federal tax. Federal tax is about $1 per pack. But across the 50 states, there are different state tax. And so like North Carolina, West Virginia, they have a very, very low tax rate. And California used to be the leader of that. In 1980-89, but now it's only ranked 38 among the states. So California really need to raise more tax. We're behind New York. We're behind Michigan, other states. Way behind. So when I look at the overall weighted tax rate, it's combined all 50 states. Yeah, and you also know that tobacco industry is very strong in the United States. There are only two countries in the world, major countries, did not sign this FCTC treaty. One is United States, and one is Indonesia.
Wendy, did you have?
Yeah, it's sort of a related question. I think one of the reasons we find taxes so effective in the U.S. is because the tax revenues are also used for tobacco control purposes, like in California. What are they used for in China?
Well, in our policy recommendation, we did make a strong effort to point out, because the Chinese health reform They put a lot of money there already between 2009 and 2012. Now they need more money because they really need to put, so they're short of money, and we made a recommendation that the earmark part of the revenue to be used for the healthcare reform in China. But in the Ministry of Finance, usually in the public policy, the public finance theory, they say they do not want to see earmark. But I think we can use this as an argument to convince the leaders that, look, you do need money in the healthcare reform. And so in our proposal, we did suggest that would be the case.
Yes?
Hi, thanks very much for presentations. I had one question in particular for Marcella. So you focused actually on good things of immunization campaigns, but in fact, these campaigns, drain a lot of health workforce. And I'm wondering if you can comment on probably, especially as I think there's some technical vaccines like measles that are injectables, the amount of human resources needed. And in fact, if you maybe looked at some of the opportunity costs, for instance, you mentioned that you couldn't see any drop in beyond the trains in IMR and under 5. And in fact, I don't think I would explain that, but perhaps, there were, a drop in terms of healthcare visits in facilities during the campaigns, and some of the children, disease couldn't be addressed and so on.
That's an excellent question. This particular campaign was somewhat unique in that a lot of the funding came out of Rotary International, and so the funding came from, sort of goes back to the question of would that funding have been available had it not been specifically for immunizations? And then in terms of how the vaccines were delivered, a lot of times they were actually done at schools and at mosques as opposed to in healthcare centers. And they did a lot of training of school teachers to actually vaccinate the children. So it was really unique in that way. But that's not to say that in a different setting that we wouldn't be concerned about the opportunity cost that you're talking about. But this was just a very unique situation.
Yes?
So my question is on the tobacco tax. Are there any tangible socioeconomic inequalities in smoking in China? And how, so are there any tangible socioeconomic inequalities in tobacco use in China? And how do you expect the tax, raising the taxes, or what do you expect the impact of raising taxes and raising prices would be on those inequalities?
I'm sorry, didn't hear the impact of raising tax on?
Socioeconomic inequalities in smoking in China.
I see, okay. Well, the smoking essentially is a social norm in China. So therefore, when we talk about tobacco control, one area we need to do is to change the social norm, change of the people's attitude toward smoking. And I think that this effort, when I report on the non-price control, those like a secondhand smoke, the impact on those things are really important one. And so China is doing a lot of effort on that, because the Chinese government, when they ratify this program, they do know maybe it's easier to do the non-price control than price control. And in fact, the good news was, again, the last December, the president who announced that the directive saying, number one, that the public officials should not smoke in a public setting. Number two, cigarettes should not be as a gift in like New Year's or wedding and so on. So it should not be as the gift. So those are really the changing of the social norm. And we hope, those kind of with the tobacco control on both non-price control and price control, it slowly has changed some of the smoking environment. So if you go to China, now you see that in a railroad station, in an airport, they're not allowed to smoke. And even hospitals are going to decline the smoking prevalence rate.
We have time for one more question. In the way back. Sorry. We have two more, but we'll do those.
Hello, I'm Dean Jameson from UCSF. Thank you, Marcella Tewei, for really very informative talks. Questions for you, Tewei, and it's about the elasticities. It seems to me there are three separate elasticities that are important here. One is how does price affect the probability that a person who doesn't smoke start? How does the price affect the probability that a existing smoker stop altogether? And how does the price affect the quantity smoked by an existing smoker who doesn't stop but who is still affected by the price? And that those three will have perhaps very, very different both magnitudes and channels of effect. And I wonder if you could comment on that.
Sure. It's very, very, very important, complicated issue. So in econometrics, that we have, usually we do a two-part model. When we have data, survey, household data, individual data. So therefore, we know the information whether they smoke or no smoke or they quit and so on. The other kind of data is the consumption data, just the sales data, which is total elasticity. So to analyze this quitting or initiation of the smoking, we need to have individual data. And so therefore, when we do two-part model, so the first part we look at, we call the participation elasticity from the two-bit model, two-part model. And then once we have the estimation, which we can estimate what is the probability of quitting or not initiating of the smoking. So that was the number we can put on in terms of the estimation for the potential number of people who quit. And then we look at for the sample who have smokers already, then we look into whether they reduce the consumption and which is the quantity of the amount of cigarette consumption. So we have also in literature, there are other studies to show that we look at the use, especially in China. Let's say you raise the price, how much of the elasticity will not initiate smoking. And that is a very important statistic. Yeah. Thank you.
Great. That'll end this panel, and we'll move on to the next one.
Our next panel is on behavioral economics, and very lucky to have Tom Hall, who is doing workforce modeling before Richard. And you come and bring us your experience for behavioral economics as well. Thank you, Tom.
Thank you. For some obscure reason, I was given two name tags with two different first names, but they want to keep tabs on me. We're about 25 minutes behind the scheduled time with a 40-minute, according to this, presentation with three presenters. So I'm going to try to move real fast on here. It's very hazardous being moderator of the last session before lunch.
Yeah, that's okay. We can delay the start of lunch. It's okay. So.
Okay. And thanks to Richard for his comments. I used to work particularly on single country, total health workforce, public and private sector, productivity and all that forecasts. But Richard's made the grand leap forward and is now taking on the entire world, 157 countries. I was going to read the first couple of lines, but you have all the information on the speakers, so without further ado, David, lead on.
Thank you. So I'm going to tell you a secret, but it's a secret you all know, which is until very recently, most doctors in American and British hospitals did not wash hands between patients. But they were a lot more likely to do that if they knew someone was watching. And people in American and British public restrooms don't usually wash hands after they poop, but they're way more likely if they know someone's watching. I was at an image of a grad student with feet up on that wasn't how those studies were done. So it seems to me that what underlies a lot of the talks, from smoking to lots of other things, adherence to drugs, is behavior change. And I'm going to tell you briefly that something you all know, behavior change is hard, and I'm going to tell you about some attempts that failed. So we all know that if people had safe water and if they washed hands, there'd be a lot less diarrheal disease, among other benefits. And we know that these things are uncommon in poor countries, that it's not too surprising that I can't get the women in Kenya or Bangladesh to treat their water or wash hands, because we can't get doctors to do it if we just tell them about germs. So I wanted to take advantage of this result I said, which is if people know someone's watching in the US or Britain, they wash hands a lot more. So it seems that you can have a norm that says don't be seen eating shit or something, and that might be more effective than saying they're germs, and this will reduce the prevalence of diarrhea disease from 5 times a month to 3.5 times. You know, maybe we can just say it's disgusting to walk around with poop on your hands and don't let your neighbors see it. We also know that in the place we're working in Bangladesh, they have these public taps, and there's no soap there. So we want to see if we just get them a low-cost soapy bottle, can we get some progress? So we ran a randomized trial. We had 2 messages of our very best germs and health message and our very best disgust and shame shit message. I love, it's the high point of my new phase of my career is I get to talk filth. For some reason, they never let me be the lunch speaker. I don't know why not. No one ever talks to me at lunch about my work. I'm not sure. So we did this in some poor neighborhoods in Dhaka, and they live in these compounds. They have these shared toilets and kitchens and water points. The standard message you all know, and our disgusting message was as disgusting as we could make it, that not too many people left. But we had some people leave, and that was the goal. We wanted this to be very upsetting because it's about, I learned how to say shit in Bengali. That's the only word I know, I'm embarrassed to say. But we had vivid images of how shit gets on hands. I invented the disgusting box, which I'm extremely proud of. And the high point of this is we put the plastic poop on. We've shown that there's leaks, and we pour water, we sprinkle water on top, and when the water comes out clear, we offer it to people and ask, would you like to drink this? So this is a simulation of an urban water system in poor countries where there's leaks in the pipes and feces on the surface, and that's how it gets in. And we tried to explain the norms. Your neighbors can spread poop, with the idea of trying to encourage people to be afraid that their neighbors would know they're walking around with shit on their hands or serving their kids shit or something, and that was disgusting. That was the goal. And it sort of in pre-test, we got it to work. People understood these messages and said they'd do everything, which is really easy to do, get people to say stuff. We did use these chlorine dispensers that are related to things that have been very effective in rural Kenya, Michael Kramer and others are associated with. And then we took this really low-cost soapy bottle, you put a penny's worth of laundry detergent in, you poke 2 holes in the top, and it's cheap enough, we hope, that it could stay in a public area, whereas they wouldn't put soap that costs a dime or 20 cents. I'm skipping, obviously, tons of fascinating details, and I promise not to use vulgar words if we talk at lunch. But across our study arms, we did not get increased use of the chlorine, or some people boil, and we didn't see more safe water in any sustained way. So what you should think about numbers like 8 percentage point increase is that's pathetic, that's part of a long tradition. We've told them there's germs. This is during a free trial. The chlorine is there on the wall right next to the water point. And we're getting 8% of people to use chlorine. People really hate chlorine. But we've done stuff with water filters, and it's very hard to get half the people to use a water filter in a free trial, just telling about germs. And the willingness to pay, I'm sorry for the abbreviation, we did all sorts of fancy ways to determine this, but was in the order of 10 cents a day was typical. So to rent, 10 cents a month, 10 cents a day would be a lot. 10 cents a month, a third of a penny a day, for the typical household to rent this chlorine dispenser. And it's hard because people might want a free ride on others, but what you should take from that is that's not a lot. We've told them there's germs, or half of them we've told them there's poop in their water, they don't like that, and they say they're going to treat their water. They don't treat their water, and they're not willing to pay much to keep it. there is variation. So these chlorine dispensers are really cheap. There might be a little market niche for somebody to go into business here, but it's not going to save a lot of babies. The hand washing was, again, we don't have a control group, but these are low numbers in the, and they're the same in the two arms. That after people left the toilet, almost 90% are walking by the soapy bottle when it's present. And it was usually present because we were refilling it. I'm sorry, we're not washing with soap. When we provided the soapy bottle, we got a statistically significant and sort of economically the smallest meaningful increase in hand washing from 10 to 14%. Now, some people didn't poop in the latrine, some just urinated or whatever, but 14% is still failure. It's a lot more than 10% percentage terms. So one thing we learned is that these soapy bottles are really cheap and we probably should have a lot more of them. But we don't know how to get behavior change. I don't know how to get, maybe some of you do. But there aren't a ton of really effective mass hand washing interventions, and this is part of the tradition of something. Providing the soap really makes a difference, the smallest meaningful difference, but it makes a difference. You can think of that as either, plus 40%, or we got it all the way up to 14 percentage points, which is not great. A lot of why it didn't work, there are two things when something doesn't have much evidence of success. One is maybe the theory's wrong, which is what scientists are supposed to do. I don't want to go there. So that's supposed to be a little funny. I think we just didn't intervene enough, which is the other thing you can always say, right? If we just had more troops in Vietnam, we would have won, sort of. We just did sort of 1.5 presentations. We got women. We didn't get hardly any men. We didn't get all the women. We didn't have a lot of reminders and stuff. It's not a community that had as strong of care of what their neighbors thought as I hoped. So we decided to double down. If you fail, instead of backing off, we're going to go to places where there is more repeated interaction, which is schools, and we're going to go there again and again because we're going to have a bunch of stories and games, and we don't get to use the word shit anymore in schools. But we are going to get as vivid as we can. We have stories and games, and the idea is pretty simple, that stories and games are about conflict, and so you should be able to make a story or game that's somewhat engaging. And lots of kids think poop and snot is fascinating, as obviously I do, but if you're appealing to 8th graders, that's often, 8-year-olds, that's often a good starting point, that when Jerry the Germ rides on a poop boat. The games can practice some of the behaviors. Here we have a tag game, but the bed net does keep you safe from malaria, or the going to wash hands can be how you unfreeze in the germ tag. And the kids can make their own soapy bottles, which is sort of nice because there's a demand side intervention, but the supply side is equally crucial. It's a lot harder to have the kids build a water filter or something, but hand washing is something that they probably can do. The older kids may be able to make oral rehydration solution and such. So right now we've done a handful of pilots, and a bunch of games and stories are lousy, but we have a subset that are really quite good. As you can imagine, germ tag kind of works, right? That way to show how epidemics spread. We're hoping to get good enough that we'd have something worthy of a randomized trial in a year or so, but we're still trying to get things that work when Berkeley students or elite Indian teachers teach. And I've been worrying a lot about behavior change for kids, and now I have to realize this is behavior change for teachers as well. And that's its whole other set of challenges that we're just starting to address. So I'd love your comments. So this is obviously, we've done one past and a quick description of a forthcoming study in 9.5 minutes. But if I haven't totally discussed it with you all, I look forward to your comments throughout the day.
A couple of quick observations on it. I was fascinated with a movie about dealing with these problems in Africa, and stand-up comics
were very effective in getting communities to talk about things phenomenon that all of us have to do. Also, my first boss was John Grant, the father of Jim Grant, at a time in Puerto Rico when they were constructing 50,000 latrines a year, but finding that because the children did not use them, basically the latrines were not effective. Delighted to have a person from UNC Chapel Hill here. I was there 8 years, professor in your department, and also director of the Carolina Population Center, and Richard was also at UNC.
Wow. I had no idea. I feel embarrassed I didn't know that, but it's great to be here. I have to say I woke up really early today, so I'm going to do my best to get through 10 minutes. I guess start by getting the slides up. Do I do it, or is it someone up there? Okay.
One or the other. Yeah, click on the one that says there.
Let's see. There we are. Okay. Great. Okay. Well, I'm yeah. All right. I'm not going to talk about shit, but I'll be changing topics quite radically to a different continent and also to HIV/AIDS. And I'm going to describe a study that we just completed in the last year and published the results this summer. And there's some ongoing work that I'm happy to talk about in the discussion if possible. So just very broad motivation for this work and some related work that I've been doing. It has to do with the fact that we have incredible set of technologies now available and innovations in the field of HIV to prevent new infections, and it's, I think, contributed a lot to the term of or the hope of an AIDS-free generation. The fact that there's evidence that HIV treatment prevents transmission in a very significant way, 96% reduction. And there's also interest now in pre-exposure prophylaxis, voluntary medical male circumcision, again, another biomedical innovation that has been shown to reduce new HIV infections. So there are a number of biomedical technologies that there's optimism about. The point of departure for, or really the motivation for this work that I'm going to talk about has to do with the fact that the behavioral factors associated with those biomedical technologies are going to be really crucial for ensuring that the kind of efficacy that was seen in the trials can be translated into effectiveness. So I think many people in the room probably working on issues related to the efficacy to effectiveness challenge, and implementation science, again, is a field that's trying to figure out ways to ensure effectiveness when implemented at scale. So what are these behavioral factors? Well, the study I will be talking about has to do with medical male circumcision, and there the behavioral issue is very simple, and as you'll see in the study, it's actually allowed us to complete the study in 1 year. It's just an issue of uptake. Going and getting circumcised is a behavioral, it's obviously a choice that men have to make, and without that high levels of uptake, we're not going to see the benefits of male circumcision be realized at scale. And similarly, I could go on about the behavioral factors associated with those other interventions, but if you think about retention and care adherence to the care cascade, that's another example of how suboptimal outcomes there could limit the effectiveness of HIV treatment. So as an economist, one way that we've tried to approach these topics has to do with going back to the basics of what you learn in Economics 101, is that there's a combination of both supply-side factors and demand-side factors that are likely to contribute to the behaviors that we observe in the real world. And so if we can identify what those demand and supply-side factors are, then perhaps we can also start to figure out some solutions on the demand and supply side that can tackle these behavioral challenges. So there's been a lot of work looking at how economic interventions can be used to modify provider and patient behaviors, and the application that I'm going to talk to you about regarding male circumcision in Kenya is going to build off of a lot of those studies. So here's an illustration then very quickly of what the behavioral challenge is here. So this male circumcision was, there were 3 randomized trials in 2007, I believe, that came out around the same time and showed that it reduces the risk of HIV infection for men by about 60%, and that prompted about 13 countries in Eastern and Southern Africa to implement plans to make these services available essentially free of charge around across the country. And you can see that about 6 years after that, there's been, I would say, overall relatively limited progress in scaling up male circumcision. You can, at least if you look at the top half of those countries, the progress towards the target of achieving 80% circumcision prevalence, which a lot of these countries have committed to, has been very limited. And in other countries, including in Kenya, you may wonder, well, why is the study taking place in Kenya when it's really nearing its target? In Kenya, the demand for male circumcision has been very high among among younger men, but has been very low, under 30%, for men above the age of 25. So there's still high HIV incidence in those age groups, and so the priority in that country has been to identify ways to increase uptake of male circumcision in those age groups above 25 years. Now, if you look at this chart again from the UNAIDS report, in some countries the problem is very much a supply side issue. So in Malawi, my understanding is that the country is not really signed on to making the services available until very recently. And so that might explain why you see 2% uptake. If no one's offering the service, then we can't expect there to be any coverage of circumcision. But in other countries, the supply has been there, the services are available, but we really have extreme underutilization of the services. And so we think we're dealing with a demand side problem in places like Kenya. And as I was saying, thinking about demand for circumcision for men, I don't want to reduce this to purely an issue of economic factors that drive demand. There's obviously a number of deep-seated issues that come up, including the fact that this has not been a cultural norm in some settings. But there are also a number of other motivational factors that may be influencing demand for circumcision. And so if you look at the literature, there's been a number of reported barriers, including cultural factors, perception of risk. So if you don't think you're really at risk of acquiring HIV, then why bother going for circumcision? But also some factors that are going to then more directly motivate the intervention that we did. Has to do with the fact that fear of pain and adverse events comes up a lot. Concerns about the sexual abstinence period immediately after circumcision for about 4 to 6 weeks. And then also economic factors that working age men in particular have been reporting, having to take time off work when they go for circumcision. So what's the intervention that we did and evaluated in Kenya? Essentially what we did is provide compensation to men who chose to come and get circumcised. I'll tell you about the details of that intervention on the next slide. But the rationale, there's a two-pronged rationale, and I want to be clear about this, particularly since the talk is within a behavioral economics session. The standard rationale is just that if men are reporting high opportunity costs and that is the barrier to getting circumcised, then providing some compensation can offset those real costs. So that's a standard Econ 101 rationale. Then the behavioral economics rationale might have to do with the fact that if you think about male circumcision, the costs of getting circumcised are very immediate, right? So the fact that men have to overcome the fear of pain or adverse events, or the men have to be willing to to have that sexual abstinence period, the benefits often might be much delayed. And so in the behavioral economics rationale, providing compensation or an incentive can provide some immediate benefits that may offset those immediate costs. So that's really the rationale. So we did a randomized controlled trial starting last year and focused on 25 to 49-year-old men in rural areas of Nyanza region in Kenya, and provided them compensation in the form of food vouchers, not cash. And the food vouchers were valid at shops in the study area, and they were offered to the men once they came and underwent circumcision. And the goal, we tried to be very clear in the communities as well as in the ethics review process, was the goal was really to reduce the costs associated with male circumcision down to close to zero, because there are some days that men will have to take time off work for. And we didn't want to have compensation amounts that would represent large financial gains. So that was clearly a concern for us from the very beginning. And we had 4 study groups: a control arm where men were not offered any compensation, a $2.50 compensation arm, which really tried to address transportation barriers, if that was really the issue, and then a moderate compensation amount and a higher compensation amount of $15. And 1,504 uncircumcised men were enrolled and randomized, and we gave the men 2 months to make that decision to come and get circumcised. The services were still available after those 2 months, but there was no compensation offered if they chose to come after 2 months. And really, we chose this 2-month period partly because we wanted to get some rapid results to share with the government, as well as with the programs that are offering these services in Kenya. Nearly done here. The results are relatively straightforward to explain. In the control arm, we had very low uptake. 1.6% of participants came for circumcision. Similar in the $2.50 arm, where we see significantly higher uptake is in the arm where men were offered 700 shillings, and then in the 1,200 shilling arm we saw uptake of 9%. And that's, as a reminder, that's within a 2-month period after the enrollment and randomization. And in logistic regression analysis, you can see the odds of getting circumcised were significantly higher in these 2 arms, not a significant difference between the moderate and the high amounts of compensation. So the bottom line is these small amounts of compensation were very effective in promoting uptake within a 2-month period, certainly compared to the control and the smaller compensation amount. If you think about it from the standpoint of cost effectiveness, we have modeling results that suggest every 5 to 15 circumcisions can prevent 1 HIV infection. So if you're talking about spending an additional $12 to compensate men, or an additional $15, given the number of circumcisions we would generate, that's certainly highly cost effective. There are some other interesting results that the intervention particularly was effective among participants who had higher risk sexual behaviors initially. And finally, in qualitative interviews, we do have some evidence that for the men who were particularly economically active and had higher daily wages, that they made it very clear that compensation amount, at least they perceived it as being too small. So that could be something to discuss after the presentation. So we're now actually thinking about what the next steps would be. We've shared the results with the Kenyan government, and they're thinking about including it in their Global Fund proposal. But we also have to think about the generalizability and relevance of this type of intervention for other settings. So I look forward to questions and discussion afterwards, and thanks again.
Jim, no introduction needed here. And
Ali, where are you? Come forward, please. This is a tag team presentation. And there we go. So what do I have, about 25 minutes? Is that right?
You're the one keeping us from lunch.
Oh, yeah. So I'm going to start our presentation off. This is a review of behavioral economic tools that could have an impact on the grand convergence that is discussed in Lancet, in the Lancet series Global Health 2035. In that a report, as we will focus on this afternoon in the workshops, there is proposed a grand convergence of maternal child and infectious disease in low-income countries to the best performing middle-income country levels. This requires increased health intervention utilization and quality. The question we are trying to look at here is, can behavioral economics help? And to try to get at that, we are doing a systematic review, which we are presenting the initial results of here. The
BE tools we've looked at so far include financial, such as subsidies, conditional cash transfers, microcredit, and pay for performance, and non-financial as well, incentives, SMS reminders, point-of-care testing, and monitoring. We are going to be reporting so far on outcomes for HIV, including ART initiation and adherence, testing and viral suppression, vaccination coverage, malaria bednet purchase and use, maternal health contraceptive use, and provider behavior, in particular in an attempt to increase vaccination coverage, improve prenatal health outcomes, maternal health outcomes, and the quality of health care. We found the papers through searching a variety of different databases, looking at citation lists and asking experts. We're using search terms involving behavioral economics combined with other terms, and also, this is not a full list, but other search terms as well. We excluded non-English studies, NCD papers, just because we're focused on the grand convergence, and anything older than 10 years. And once we looked at studies, we included them if, in fact, they had a behavioral economic intervention looking at the indicated disease areas. We used an effect measure called relative risk reduction. That is the amount that an intervention reduces adverse outcomes. So a score of 1 in this scale means a perfect elimination of the adverse outcome. 0 means no effect, and less than 0 means harmful. So if you have a control group with a risky or a negative outcome of any type, whether it's lack of vaccination or a bad health outcome, and this is the intervention group, this represents the difference here, and if we take this difference and divide it by the control group denominator, that gives us the RRR. Here it is in equation form, the incidence in the control group minus the incidence in the intervention over incidence in the control group. And we put, studies are not necessarily reported this way, we transferred everything to this metric. Ali, if you want to point. Sure.
Thank you, Jim, for the clear, brief background. My name is Ali Mirzazadeh, and I came to UCSF in 2012. It's a great pleasure to be here and talk about this review. As you can see, as a usual forest plot, we have the study level individual effects, and we have the combined effects for this group of studies. And for here, I'm going to present the HIV-related outcomes. For lack of adherence, pretty much the SMS and call reminders would improve the lack of adherence by 40% with the significant significant results. For the HIV testing, SMS reminders and informative or motivational reminders would improve also about 28%. Getting the HIV testing. For viral suppression, the effect is less, about 60%. It's not statistically significant, but however, it shows a kind of positive results. For the ART initiation, using the point-of-care CD4 testing at the site at the same day improve a little bit. Not significant. Anyway, overall, we can see a kind of improvement for this kind of tools for HIV-related outcomes. For the vaccination, we look at different vaccines and program. Being on schedule has effect. The conditional cash transfer improve being on schedule vaccination about 60%, not statistically significant. The most effect was seen in, I believe, oral polio and Hep B vaccination in adults. Pretty much everything is effective with the exception of BCG and DPT and on schedule for the children. For the malaria-related outcomes, using the bednet and use of purchasing the bednet and use of the bednet and with the intervention of subsidy and or distributing free bednets, the use of bed improved by about 50%. It's pretty much impressive. For the maternal health-related outcomes, looking at the outcomes like using contraceptive, overall conditional cash transfer not very impressive. Here, there is something here. We can see the same effects as we did on the previous related outcomes. The overall is about 0 effect. For the provider behavior performance, pay for performance may improve the adult care by about 50%, but the effect is much less for maternal health related outcomes and child health. For the provider, again for the private provider skills and performance, monitoring and real-time monitoring and providing training and supportive feedbacks may also contribute to improving the performance in child health, better than even cash transfer or pay for performance, but not effective for also effective for the provider performance by 20%, improving the quality of the service. So the take-home message is that the behavioral economic works may work more multiple disease. This is an intervention package that should be considered to reach the Millennium Goals and also the grant coverage. However, the effect size is very large, and the maximum effect was about 60% in vaccination. We observed that. For the provider performance, pay for performance improve the quality of health for adults, but not the maternal and child service. And providing supportive monitoring and feedback could improve the provider performance on child health. Maybe there is a conclusion here that paying for performance would benefit adults, not the children and the maternals. There needs to be discussion about this. And the behavioral economic services appear to be a kind of resources and toolkit to improve the important main health-related goals. Thank you.
Jim, you want to set the amount of time available for questions?
Why don't we do, 10 minutes is fine. We'll have a little bit shorter lunch. Yeah.
Okay.
Ali.
Do I see any questions? Great.
This is a psychiatrist's question on circumcision.
You mentioned that one of the barriers was pain, but all of us have different emotional investments in different parts of our body, our hands, our face. We're very attached to it. Most men are emotionally very attached to their penis. And so it seems to me there's much more than pain as a barrier to getting this. And my question is, do you have any information about people's, men's concerns about how things are going to turn out and how workable is this apparatus after the surgery? Because it might take more money to overcome that.
Yeah. Well, I'll say, I think there's been, in Kenya, more than other places, there's been a lot of work done on just general perceptions of circumcision and how men actually feel about it. I have not seen a lot of evidence, and certainly not in our study either, did we find a lot of evidence that men are concerned about the procedure, perhaps reducing sexual pleasure or having significant adverse events per se. Now, pain tolerance is something that obviously varies across individuals, and the degree to which that's the overwhelming barrier also varies from individual to individual. But I would say the 60% is the coverage now in Nyanza region, and in other parts of Kenya it's much higher. So I have not seen a lot of data that support this view that the reason men are not going is because they think it's going to reduce sexual pleasure, or it's going to somehow not be perceived as attractive by female partners, et cetera. The evidence to some degree is suggesting the opposite or no difference whatsoever, no difference at all. But this is just to comment a little bit further on it, though, is yes, the pain issue is going to vary from person to person, but if we take this notion that it's this sort of immediate psychological cost, we're not saying that the compensation amount necessarily is going to offset it completely, but just the existence of an immediate benefit can offset that immediate cost to some degree, right? Whereas if you look at it in the absence of the incentive, there's no, to some of the men at least, there's no perceived immediate benefit from going and getting circumcised today, right? So that was the story.
Another question there, and I just comment that the whole business of whether once you're circumcised, you then increase your hazardous behavior and whether that would partially reduce the benefit. Yes.
Yeah, I don't want to be a traitor to our discipline of economics, but this question is to all three of you. And that's about the why. So for instance, from the Global Health 2035, one of the things we know is that in fact, scaling up family planning will have a huge effect on helping to meet the convergence. And so the results here showed that in fact, for contraceptive use, if I saw your slides correctly, that was an area where we don't show successful behavioral economic toolkits. And so one question is why. Similarly on why things don't work in Bangladesh, the why. And the same goes for, why was that rate from 5% to, or 9%? What's the why there? So I guess the question is, can we work within the context of randomized controlled trials? Where is there scope for understanding the why?
So I think in my study, we have anthropologists on the team, and we're trying to explore the why of the failure. And I only had 10 minutes talk, but we do have hypotheses about the lack of cohesiveness in the groups and the brevity of the message, that it was effective that day, but it wasn't repeated. But we have a whole qualitative report I'd love to share with you, and I got no shame. You can read all about poop you want. But I think motivating that is RCTs are not a replacement for watching and talking. And
just a comment along those lines, Carol, that we had a qualitative study as well that actually went back to the men who chose to get circumcised, as well as those that didn't. Many of them obviously didn't get circumcised during that 2-month period. And that did allow us to learn a little bit more about what the intervention did do for them or did not. It goes back to one of the points I made, that there's obviously competing, there's a range of barriers that are going to be at work here. And for some of the men, that was not the issue. Men said to us that it's not the cost issue, or it's a cultural concern. But we also got to learn some other things about what was the incentive amount that would have been adequate, right? So there's some insights that could be learned that way.
And as you can see, we focused on the numbers rather than on the why, although as we write this up, we'll look for whether the authors of the studies had a view of what the why was, why there were failures, for example, with contraception. So maybe we'll be able to shed some light on that. I'm going to take the opportunity of having the microphone to ask David a question. David, in the way you presented and your free use of certain words, were you intervening on us? And if so, did you get IRB approval?
I have hand sanitizer here. If anybody before break wants to come by.
One more question. Yes.
This is a question for all three of you, or the entire panel. It seems to me that a lot of the behavioral economic interventions work well when you're talking about a single intervention that is this discrete, you had one intervention and one outcome. Whereas if you're looking for sustained behavior change, a lot of these things may not work. So ARV initiation seemed to work, but HIV, viral load, and long-term outcomes were not affected by behavioral economics interventions. So what do we do about behavior change that needs to be more sustained? Are there ideas? And then specifically, paying for a particular behavior then distracts from other behaviors. And so do we end up with a system where every positive behavior needs to be incentivized?
Well, there's a funny use of words here, because I I think of paying for stuff as being old economics. I mean, the immediate payments are different, as opposed to conditional cash transfers like economics. Thinking of it in terms of present bias or changing norms is what I think of behavioral economics. So that the question for me would, since I don't use another thing, I'm great on monetary incentives. I only look at places for this behavioral stuff where they don't work, because they're a lot easier. But I think the answer is you get sustained change when you change norms. The only thing is we don't know how to do that. So I tried to pick something that was pretty easy, because there's only, as far as I can tell, 3 universal norms, which is don't eat shit, don't be seen by your neighbors doing disgusting things, and don't sleep with your sister. And I'm taking 2 of them and just trying to line them up and hoping we can change norms. How we would turn that into also norms about cleaner cook stoves, don't use your old stove that kills your babies, I really don't know, but if I can do the easy one, which I failed at so far, then I'll work on the harder.
Any other comments here? So, thanks to our panel and good evening.
Thank you, Tom. That was terrific moderating. We're gonna reconvene in an hour. So at 1:35 or 1:40, we will continue with the other panels. There are interest tables at lunch. So if you want to go talk to folks interested in the same thing, go find the sign.
All you're doing is not necessarily behavioral economics. That's like a separate. Yeah, on the sustained part. Like, works for.
All speakers and panel moderators, too, please collect at the staircase for photographs.
I guess where I was going was that if you look at
Carol, good to see you.
you look at outcomes that are measured in 2 months versus outcomes that are measured in 2 years.
Yeah. Yeah. And that's like a any really well done study. So smoking cessation, exercise. I mean, it doesn't apply for the meal cessation thing, or behavior, but yeah.
Photo taken?
You have to see studies where they focus on a behavior and they just look at it during the incentive period, and that's not very satisfying. So, yeah.
I was wondering if, like, Jim's, like, instead of just breaking it out by intervention, would be an interesting thing to plot it by.
Duration effect. For some behaviors that makes sense.
Yeah.
For the behaviors where that makes sense, yeah. Right.
I'll see you next week.
Oh yeah, good to see you. Yeah, looking forward to it.
I can remember. Early 70s.
Oh, okay, alright.
Before you were born.
Sounds good, looking forward to it.
You have a good analyzing mind.
These are all. Yeah, I know. Who is she? Is that? She's on February this past year in monthly, so we were one of the affordable ones in countries every year. So we actually, she set it up. That's the same. Site visits.
I went with the group to basically full offense and anything you have, they will. Okay. But it's targeted to the LGBT.
Yeah. Economics that's the behavioral science, and they have that. They have that trait. It's just that they have a little more rigorous testing. That's the one thing that I would say
And you can't settle for that.
No, I want to know what Sandy's
What?
So there's a question of the solid enough.
Yes, you did. That's what you said for Frida.
How much
Do you guys have results? Where are you? And you're going to look at, remember we were talking about this last year, and you're going to look at afterwards too.
Yeah, so they get 6 months of intervention, 6 months after.
Oh, so you'll actually have all that. Because you're not running out of money. Right. That's not, yeah. But like, will you be really unpowered as a result?
No, we're going to do.
Incentivize?
Showing up.
That's interesting. I've always wondered about that. Why is adherence that? It's supposed to, yeah. If you show up, is the idea that if you show up to the clinic, you're going to have your meds with you?
Yeah, well, so we were going to incentivize adherence, like either picking up your meds or so viral suppression in the past, you can't go back and then our partner.
You can't incentivize meds.
No, you can do pharmacy. Very easy. Our partners, no, because we don't want you to have clinical.
Yeah. Right. So you could start by looking at retention for a step.
But with the anti-jet stringers, which was that, yes, people actually got the drug, but they didn't take it.
Right.
So, I mean, you know, that kind of, I mean, that's.
So that's where.
We desperate Jimmy.
Oh, sorry.
Wait, is it okay? Can he?
I have to be able to.
I know, go, I'm just checking my
Yeah, I was just even the education.
You're what? Going to have lunch at this table. Is it all right if he leaves his computer here? He's doing should I take it?
If you're concerned about it, I mean, we don't really have security, but if you're concerned about it, I would keep it with you.
What's harshest?
East-West Productions. Google it. Just got me into when you're switching places tonight. Standing in front of 3 microphones, it took me they said each one was $800,000. Not 80,000, but 800,000. Well, I said, well, who records this? He said, well, you know, the Chili Peppers. This is where the Stones is. This is where the Beach Boys is. This is what blah, 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 blah. So I went on and started to look at it. This is a couple of years. Well, he had some small ones, small companies that he did a 10-city tour with a band.
Test.
A couple of weeks ago. I played all his live.
1 2 1 2 1 2 1 2 1 2 1 2.
Well,
Having the jazz
I don't know about dual scrolls, but if he gets into it, yeah. Because there's a set-aside number of slots. I don't know. Better than that. Sometimes it is. Slightly easier. Do you want to make some announcements? Okay, so they don't count freshman grade. For the last 2 years. Anyhow,
Elliot, that's my assignment for you.
Okay, folks, I think we're going to reconvene. Welcome back from lunch. This afternoon we have talks by myself and Doug Owens and Richard Scheffler about what's going on at UCSF, Stanford, and UC Berkeley, respectively, in global health economics. This is a little bit of an experiment because we have no standard format. You're going to see different approaches to summarizing this. I will start us off with an overview of global health economics at UCSF. First of all, our working definition of global health economics is quite broad. We say it's the use of economic methods to understand the determinants and effective health, and have crudely divided this into the micro types of studies, which typically are about diseases or intervention focused, and the macro types of studies focused on systems. Typical topics are cost of illness, cost of screening and prevention, efficiency, cost effectiveness, behavioral economics, translation, particularly from bench to clinical tests and practice, and productivity effects. At the macro level, delivery structure, workforce prices, financing, resource allocation, scale up and sustainability, access to care, quality of care, burden of disease, and relation to health. And we have work in most of these areas at UCSF. We started to think about global health economics as an institutional enterprise about a year and a half ago in the spring of 2013 when we formed GHEcon, Global Health Economics Consortium. The idea was to try to find what is going out through the disparate parts of UCSF in these general areas. I originally approached Jaime Sepulveda, head of Global Health Sciences, thinking that I knew of maybe as many as 15 or 20 people working in these areas, and I thought it would be great to connect us. He encouraged me, and it turned out it's quite a few more, as I will talk about in a moment. We wrote a mission that GHEcon promotes the use of state-of-the-art economic analyses to increase the impact of public health and clinical science to advance the health of people worldwide. And in that mission, we identified the notion of precision health policy. That is the use of evidence to inform locally adapted health strategies and interventions in order to achieve large and lasting health gains. And this consortium includes efforts in technical research, collaborations, and innovative teaching and training. And up until now, officially speaking, GHEcon is just UCSF with many supportive friends outside. Doug actually is the chair of our external advisory board, and with this meeting, which we're co-hosting, as you all know, we hope that's the beginning of extending GHEcon to being a multi-institutional enterprise. I'm going to talk about a little bit about our teaching, and then a little bit about the kinds of research we do. As you can see here in this list, we have about 9 different health economics courses covering quite a range of areas, basic finance and economics. We've got a course that I've been teaching for about 18 years on, where is my course? Here we go. Cost effectiveness analysis. I've got an overview course here on global health economics. Got a health systems and financing course. We cover a lot of territory. What you don't see on this slide, but which I want to emphasize, is that our failing is that it's very sporadic. We have many training programs at UCSF for doctors, nurses, global health students, and we have courses targeted to each group with no or essentially no cross-registration. So just because a particular course may be, or a particular topic may be covered in a course or even two courses doesn't necessarily mean that people are allowed to cross-register, have the right schedule to cross-register, or can afford to cross-register, because some, depending on their status in the university, they may not be allowed to take a course without paying a tuition, which is often quite steep. So we now have this inventory which we're trying to keep up to date on our course offerings, but we are also struggling with how to make the basic health economic skills more widely accessible. Toward that end, we are working on a compendium of global health economic competencies. We've done some of this work. Joanne Spetz and George Swai and others did a nice piece, which is now published, on health economic competencies, which is U.S. focused and a very nice piece. We're trying to take it up a level in terms of thinking systematically about what's happening on the global setting. The idea of doing this exercise is to guide ourselves, but also anyone who's interested anywhere at all, to think about what's the set of skills and knowledge that someone interested in health economics could consider. We've provisionally divided this world into health system structure, and then performance, health and wealth relationships, influencing behaviors, which includes implementation science and behavioral economics, tools for description and analysis, tools to inform priority setting and the impact of technology. And within each of these we have several categories. For example, here, health system structure has categories in delivery, infrastructure, financing, and payment. And for each of the areas that we list, we then, it's not fit onto this slide, but we then indicate the specific content for a basic understanding, what you might teach, say, everyone in a medical school class, medium understanding, maybe someone wants to learn a bit more advanced concepts, and then advanced, which is basically hands-on work doing a project or two. If any of you is interested in reviewing what we have so far, helping contribute to this enterprise, it is highly inclusive, and would love your feedback. The hope is to have a truly comprehensive set of competencies, and then a particular program can choose which of those to focus on. Now I'm going to switch over to what we're doing. And in one of the things that was handed out at registration, you saw a bullet grid that looks kind of like this, actually exactly like this, except I didn't fit the whole thing on this page. What we have here is a list of people in GHEcon. The full list is about 40 long. This is the top part of the list alphabetically. And we've divided the areas of interest and activity into health condition areas, so chronic disease, infectious disease, et cetera, and into methodologies such as cost effectiveness, behavioral economics, et cetera. The filled-in bullets are areas of focus. The open bullets are areas of people who are working but as a secondary area of interest. And the intent here is, first of all, to help us understand ourselves, to understand what we're all doing, and to foster connections both among the people who are doing the health economics and also between the people who do the health economics and other potential partners, such as clinical researchers. On our website, we have this grid. We also have various levels of greater detail. We have a narrative version that's quite concise, and then each individual person in GHEcon has a roughly one-page profile that focuses on these issues in more depth. We also have lists of projects and publications. So again, the idea is to foster interconnectedness. Obviously, a conference is one example of that, but it's not just the conference. Here's a sampling of UCSF projects, necessarily highly selective, but gives you an idea of our breadth. I want to importantly highlight Global Health 2035, the results of the Lancet Commission on Investing in Health, with areas around costs, financing, health impact, and cost benefit. That was a commission led by Dean Jameson, who is here today and is now at UCSF. Gavin Yamey was the primary writer, is here. Colin Boyle, very much involved, and others as well. DCP3 is a project that's based at University of Washington. Again, Dean has a leadership role there, and Carol Levin and Stefan Vergey, who are here, and others have a role, but also many people at UCSF are involved in the DCP3 report. The other interesting, again, somewhat random sampling of work, Renee Shaw has done terrific work on the huge variation in hospital and emergency department charges in the United States. We've got CEA work in genotype-guided therapy from Kazi and another analysis I was involved in, disease testing strategies that Elliot's worked on, and Jennifer Lay, John Roberts, and myself again, service integration, particularly overseas, some work we've done. Cost and cost-benefit analysis of malaria elimination, led by Jenny Liu and Ingrid Chen has done some of that. Behavioral economics of malaria diagnosis and treatment, Jenny again and Dominic Montague. Tobacco and healthcare and other spending in California, Wendy Max is here today, and Jim Lightwood. And in China, Haiyan Sung and Wendy. We've looked at a lot of work on costs of quality improvement in Myanmar, Dominic. And I've done work with Alia Jawani, work coming out on the administrative costs of billing in the U.S. healthcare system. Patient preferences, Leslie Wilson's been doing some on that, along with Jeff Belcora as well, doing other related work. I will end with our first big success out of GHEcon, but also involving our partners around the Bay Area. We applied to the CDC for a cooperative agreement to assess the economics of prevention for multiple diseases, and created a consortium called CAPE to assess prevention economics. This was a project that I think, fair to say, might not have happened without GHEcon. We were able to move quickly, and we'd have many of our connections in place. We'll be looking at HIV, hepatitis, STIs, and TB for the United States. The people involved are UCSF, Stanford, UC Berkeley, the San Francisco Department of Public Health, and PATH. We have 39 investigators, of whom about half are modelers and/or economists, and 19 are clinical and/or policy experts. The technical work will include CEA, but also CBA and health and cost burden work, also some systematic review. Our award is 5 years, up to $8 million. The budget ups and downs make that a little bit uncertain, but that's what the award says. We will be doing many different analyses, and we hope that we will be advancing and coordinating methods across diseases. And of course, this being the Global Health Economics Consortium, we hope to take the work and extend it to global setting, particularly LMICs. That is a quick snapshot of what's going on at UCSF. To see what's going on, what did we say? We would go east or south for the next? Does it matter? Who wants to go next? Richard?
Well, I'm here.
Richard? All right. Let's see if I can get you queued up.
Fire me up.
Fire you up. All right. Here we go. This one works.
Okay. Well, thanks, Jim. It's hard to go up against that massive amount of material and that he's been putting together for a few years. Quite impressive. So when Jim asked me to do this, I said, well, our campus is a little bit different at Berkeley in that we're individual professors and we basically don't really talk to each other. We have our own little research groups, we have our students, and he said, well, don't you know what's going on the campus in health economics? I said, well, I know what's going on my floor in my building. That's about it. And there's 3 or 4 people around, but the answer is no. And so he said, well, you know, his can-do attitude, he said, well, I'll find out. I'll let you know. And I wrote back, you know, like, good luck.
2 weeks later, he wrote back and said, "You were right. I couldn't find out anything." And so, not quite anything, but not much. Because people just keep to themselves. They write their papers, they publish, and the reason for that is we don't actually affect real people in real lives. We're not a medical center. And what we do is very detached, and the work we do comes out 2, 3, 5 years later. There's no immediacy to it. It's a totally different atmosphere on the Berkeley campus. School of Public Health slightly different, but off of that. So he said, "Well, you got to give a presentation." And I said, "Okay, I'll talk about myself." So he said, "Good start." So I had some slides, so I'm going to show you some of the things I'm doing in global health. And then I'll talk about selectively a few of my colleagues, and also after that what we've been able to find out, Jim and I, by sending various nudging emails to various people around the university. So with that as an introduction, so about myself, this is a course that I teach. One of my students is actually in the room. It's a seminar. And actually, I've taught it for 6, 7 years now. It's a course called Global Health Economics. I don't know if Dean is in the room, but he was one of our guest honored speakers. We bring in 3 or 4 people, and Dean was one we were lucky enough to have. But it is a seminar. I, by design, keep it small enough to be around one table, which is 14 or 15 students. There's a pretty heavy demand for it, and I don't teach it by country, I teach it by theme. And then when we do some presentations and the faculty talk, they give country examples. So it's not about countries. It's not about this kind of country or that kind of country or this kind of system or that kind of system. It's about global themes with country-specific examples as you go on. So that's the way I've cut it up. So the general themes here are financing, global healthcare systems, insurance and payment. Of course, we're an economist. That's what we talk about, you know, how do you pay for healthcare? How do you raise the money? What are the different payment mechanisms? And the latest buzz, as you saw from Jim's presentation of the literature, of course, this is all this literature on pay for performance. Then for my presentation this morning, we obviously have a section on the global workforce and shortages and how to do that kind of work and particular country examples. Then there's a big theme on public-private partnerships, which is quite important and going gangbusters all over the world as countries are finding they really have to partner with the private sector, both to raise capital, but also to get new and interesting and innovative ideas. So that's a big theme. And then reform. Excuse me, every country is doing some kind of reform. We deal with skill mix. We had Dean to talk about the Lancet report, which is incredibly important in my view. We had Taewei to talk not about his smoking work, but his work on reforming the healthcare system in China. You only heard part of Tae's portfolio, but he literally has the ear of the Minister of Health in China about the reforms going on there as well. We had our Dean Sepp come talk about his work in Mexico. Will Dowd came to talk about Costa Rica, the miracle there on primary care. I'm doing some work now in Spain on the public-private partnerships in a place called Alcira, which is a long-standing public-private partnership. And we had some speaker, Jed Friedman from the World Bank, talk about some of the bank's current work on pay for performance in Zimbabwe and Rwanda. So that's my course, and that's the kind of, it's the only course on the campus called Global Health Economics. But we have a very large and distinguished economics department. Half of the Nobel Prizes the last 10 years have come out of that department. So it's pretty high level, and people do dabble, but they're not totally in the field, but there is some really high-level, classy work going on there. I have a training program now. I'm into my 16th year, and supported by the Fogarty Institute. That's part of NIH, in case you don't know. That's a part of NIH that supports global work and global training. So I train students in mental health. That's the other part of my portfolio. And currently, I've been training in this region of the world. I started in Czech and Slovakia, but now I'm working in Romania, Moldova, Bulgaria, Serbia, Albania. We train students in how to do health economics, health services research in the mental health area. So we do some of it in country. I bring a team of people over, and then we also have them come to visit here for a couple of weeks as well. This has been going on for...
Richard, can you move closer to the microphone?
Oh, sorry. This has been going... I can't... Yeah, is that better? Yep. Okay. Might have told me that 10 minutes ago. And anybody hear anything I said? Yeah, okay. I don't have to repeat it. Good, okay. So we have a book we're working on now with all the postdocs. I've had, I think, 120 postdocs through this program. So it's quite large. And not at the moment, but at any particular time, we have about 20 to 30. So they'll be coming over again in January, and we give them short courses and et cetera, et cetera. They've had a very good track record of publishing afterwards. These are some of the topics they're working on in mental health. Access, family burdens, and stigma is a big thing in that region of the world, as you might imagine. We're looking at the referral system in oncology. We're looking at the issue of aging and some workforce kinds of projects. So those are the work groups. The other thing that I'm very excited about is I agreed after a lot of years of badgering by this publisher, World Scientific, to do what's called a handbook. Handbooks are a new name for what we used to call encyclopedias. So I'm agreed to edit a 3-volume handbook on global health economics, all you wanted to know about it. So I'm pretty far along now. It has 36 chapters. I won't embarrass her. I think she's left one of my authors from Stanford. Is she still here? No, she's left to get back to Stanford. It's in the room. And so I didn't want to go through each of the chapters because I had them on the slide and Jim told me it was too busy. So I always follow his advice. So volume 1 has this title. There are 12 papers, and the one that you would know about from me is on pay for performance. The second volume has more papers on it. This one is health determinants and outcomes. And this is actually the author I was talking about. You heard her this morning from Stanford, one of my authors, and that's her professor from Harvard. Tay Wei's involved in the one on smoking. Catherine Phillips from UCSF did the one on genomic mapping. And Will Dell and the dean and a student did the one on incentivizing healthcare. But there are essentially 12 chapters in this volume as well. I just picked the ones from the local folks. And then the third chapter is on, so I guess I finished that. Okay, I won't back up, yeah. So the other thing I have coming out, which has some of the co-authors in the room, is the World Bank likes these things called toolkits. They do a bunch of them, so I just finished a toolkit on how to do planning and resource allocation and projections for the global workforce. So you heard it in 10 minutes, but there's a 280-page book about it. So I just finished it, chapter 1, and then I had Jenny involved in Chapter 2, and then there's, these are my co-editors, authors, actually funders, but they like to put their name on the book. So from the World Bank, African Development Bank, and WHO, and it'll be out in 2015, about 6 months from the World Bank. And the bank is nice because they don't sell their books. I mean, they do sell them if you want a hard copy, but if you want an electric copy, it's actually free. So it'll be online, and it's out for distribution. So I'm not pumping this book to make any money off it because I don't get any money off of it anyhow. But anyhow, it'll be out, and I'm quite excited about that as well. So, so enough about me. I think I've, and so our dean, Stefano, this is what he says he's working on, other than trying to get us more money for the School of Public Health, which is really his job. He claims that he's working on these things as well, and I won't detail them. I'm just going to try to go a little bit more quickly. Taewei, you've heard about tobacco, but also the China project and reform of the Chinese healthcare system. There's Will, who's our Kaiser professor and dean of research. I think we have more deans at Berkeley than we have faculty, and maybe it's a way of paying people more. It's like being a vice president of a bank, but Will is the dean, and his job is actually to put all this stuff together, so I'm simply helping him along. So he's working on HIV, he works in Costa Rica, and he's doing some work now in smoking cessation in Thailand. David you heard already, so I won't go through that. I know about David's work because he's a colleague and friend, so I was able to find out what he was doing. Ben Handel is a former postdoc of mine from RWJ. He's now assistant professor in the economics department, and he works on healthcare insurance markets, and he's starting to work on that globally as well. Michael Katz is working on a report for the president, the economic report, and there will be some global issues in there. He's actually drafting it. So you see we have pretty high-level folks involved. Enrico is working on Superfund money and cleanups, infant health, in the economics department. Mahaya is assistant professor, UCLA, University of California, Los Angeles. Well, how did this get in here? Where did that come from? I don't know. Where'd you get that from? Oh, I don't know where that came from. I don't put UCLA stuff up here. That's Katie who runs my place there. It's your fault. You messed up.
I think that the UCLA part might be a mistake.
I think that's a mistake. Typo. Scratch that. Take that off the tape. Paul Gertler is a one-man show, and he's in the business school and actually the School of Public Health as well, and Paul is doing numerous kinds of things. He spent 2.5 years at the World Bank as a senior health economist. So he knows the people at the bank, the data, the funding, and so Paul has just a whole bunch of projects, and you can kind of take a look at those if you like. And let's see. So the other thing I learned from Will, and this came late yesterday, is our dean has, as new deans will do, has been conducting a strategic plan. So he believes, and I say that believes, that he has the faculty support to work on global health and climate change and economic inequalities. And he also believes that he has the support to get a formalized agreement. This is big time if it happens, with UCSF to promote collaborations and increase Bay Area profile as a leading center for global population health research. So this is on his agenda. He's processed it through the school, and he believes he has faculty support. He can do it whether he has faculty support or not, because he's the dean, but essentially he's going to be moving on this. So this is big news in case you guys don't know it, but This has been formalized at our school in various faculty meetings. And there's some research going on in now food production, nutrition. We have a very good nutrition program and a department of nutrition as well to deal with obesity and non-communicable diseases. And we do a lot in the environmental area as well. There is a lot of interest in the adolescent period, which affects the life course. So there's a lot of people. We have a group in behavioral health, and it deals with a lot of issues on life course and shocks and during the life course, and looking at what happens later, and dealing with the issue of social determinants. We're doing a lot of promotion now and working with technology firms. And we're also into this big data idea that made Jim's program. Our biostatisticians are essentially gaga about this, and they actually want to hire people to do this, to actually teach it. So I think it's likely to happen. We'll be recruiting professors in that area. So we have a bunch of centers, and this is probably a partial list, but basically there's a population center that Will has that does global health. There's a Center for Effective Global Action. This is part of the Blum Center. There's a Center for Global Public Health, which is in our school. There's a Center for Economics and Demography of Aging. And then there's my own Center for Global Center for Health Economics and Policy. So this is a partial list of centers, all who do some, but almost all of their work in the global health area, but at least a good chunk of them. So when you add these people up, if you can, that it's a formidable group. There's no doubt about that. And there's more. There's a behavioral economics group. We had a meeting 2 weeks ago on behavioral economics and health on the campus. We had the keynote speaker from the World Bank. The World Bank puts out, Dean knows this, a report every year, a bank report. And I know he was involved with one or more of them, but this year's report from the bank is on behavioral health economics and global health. And so we had a speaker who was the author of the report, so we have a sense of what's happening. It'll be out pretty soon. And that meeting of the Behavioral Economics Group will be an annual meeting. Just happened 2 weeks ago. Thank you very much. No discussion.
You, Richard. So cue up Doug.
Thanks very much, Jim. It's a pleasure to be here. We are delighted to co-sponsor the day today, but I should be crystal clear that Jim did all the work and all the credit should go to him and his colleagues. We thank Devin for all of her help. We are delighted to be part of this, and Jim has, as usual, been extremely humble about his role in developing GHEcon and CAPE, which is a huge success, and we're really looking forward to participating in all that. So thanks to you all. It's a special day, or it's the day before a special day, you probably know, because the Stanford-Cal game is tomorrow, the big game.
Go Bears!
And I've been hearing that all day, I hate to tell you. And so the reason, I'm sorry I missed this morning's talks, but I teach a course, and the first thing that's happened, I was meeting with students, and this woman walks in to the business school at Stanford in a Cal sweatshirt, and I'm like, do you know where you are? And then I go to my own center, and one of my staff is wearing a Cal sweatshirt. She's now available. She's terrific. She's now available for employment. Perhaps you're looking here. Anyway, for those of you who are football fans, tomorrow should be pretty interesting, and more interesting probably than many of the games in recent history. So let me just tell you a little bit about what's going on at Stanford. We have a fair amount of economics in general and some health economics, and I'm just going to give you a very brief overview. So I'll tell you first the centers that I'm in, two, the Center for Health Policy and the Center for Primary Care and Outcomes Research. And our mission is to improve health through interdisciplinary quantitative research on health policy. Very similar idea to the mission statement that Jim just showed you. Our research agenda includes comparative effectiveness, cost effectiveness, national and international policy research, patient safety, etc. We are hoping and aiming to address important national and international clinical policy and health policy questions, and to try to be at the forefront of innovation and methods. And our CHP, our focus is really part of the our focus really on international health. We're part of the Freeman Spogli Institute for International Studies, which is the interdisciplinary institute, the independent institute at Stanford that studies things international. So we work with health economists, of course, but also political scientists, sociologists, people from a very broad array of disciplines, and study health and governance, health and economics, of course, health and security, etc. I also want to tell you about the Center for Innovation and Global Health. This is run by Michelle Berry, who I'm sure many of you know. Their mission is interdisciplinary cross-campus dialogue and action in global health. They have a number of research initiatives that are there. I think one of the key things that CIGH has done is educational initiatives. For example, the Stanford-Yale Johnson & Johnson program, where they send about 60 physicians to 6 overseas sites per year. We now have global health career tracks, both in internal medicine, emergency medicine, peds, anesthesia, neurology. It's new. It's really all credit to Michelle for that. Open access MOOC courses, and then the Stanford NBC Global Health and Media Fellowship, and overseas field partnerships. I'd also mention that we work very closely with the Department of Health Research and Policy. Mark Lackey's here from HRP, where there are people just like us, health economists and health services researchers, who also do quite a bit of international work. I'm just going to very briefly go through a few people and tell you who they are, and just to give you examples of some of the kind of work that they're doing. Jeremy Goldhaber-Fiebert is a decision scientist in our center. A couple of his projects: the school lunch programs improve nutrition in India, how to use new technologies in health systems, innovations to combat tuberculosis. He's working with Sanjay, who you heard. You heard Iran talk this morning. His research is in global health policy, including cost effectiveness and modeling. He's also doing a great deal of work on the effect of aid in health. His modeling is on HIV and TB. He's evaluated health outcomes related to PEPFAR, the Global Fund, etc. He's done some very interesting work with that, and evaluating the mechanisms by which climate affects disease and mortality. I didn't mention it, but there's a whole other independent institute at Stanford, the Woods Institute, that looks at climate and related matters. Sanjay also spoke this morning. He also does modeling and other global health work on optimizing diabetes and screening and treatment in India, studying CVD risk factors, integrating international cohort data into obesity and type 2 diabetes models, and also looking at nutritional programs. He's got a very broad program of research, and that's just a few of them. Paul Wise, who many of you know, is one of the leading pediatricians in global health. He works both in global health and in domestic work. Analytic guidance for the reform of child health in the U.S. has been a major issue, and Paul has helped develop what I think now is one of the really premier groups doing child health policy in the United States. Then using big data to identify the etiologies of preterm birth. They have a lot of funding from the March of Dimes to do this. And then analytic guidance for improving the health of children and women in areas of political instability and conflict. This is his Children in Crisis project, which is a super interesting project with political scientists and others looking at areas of completely lacking or terrible governance and security problems, and how to deal with child health in those areas. Marcella, you heard from this morning. Marcella, I don't know what all you learned about her, but she is probably the only infectious disease trained economist in the United States. She is the only one in the United States, perhaps the world. We were delighted to have her come to our centers. She's interested in antibiotic overuse and resistance. She's also looking at, you heard about the turkey immunization project. She does historical economics and development economics and has done some just extremely interesting work. There are many other people spread throughout the university, and I won't try to go through any more, but I would say at our centers and in the Department of Health Research and Policy, our main areas of focus are health economic, decision sciences, development economics, and health law now. We have recently, over the past 2 years, recruited 2 of the very best health law scholars in the world to Stanford. And so that's a new area for us that we're incredibly excited about. And some of it does have to do with international health. A lot of it's domestic. And so those really are the main areas. And again, I just want to give my thanks to Jim and everyone up here and tell you how delighted we are to be a part of this. Thanks very much.
Any questions for me or Doug or Richard?
Yes.
Could you say a little bit about Stanford University's big grant to look at big data?
I can tell you, but I'd have to kill you. No. So there are actually a couple of initiatives going on, and I'm not the best person to talk about that, but there's an initiative within the medical school to look at big data, and there's a reasonably large planning grant in conjunction with Oxford. And then there's also university-based initiatives and big data, and that I don't know too much about. The other thing I probably should have mentioned that's going on, and there's a lot of overlap with the big data initiative in the School of Medicine, is the new Center for Population Health Science. I'm one of the co-directors of that center. And many of the issues that we would study or hope to study into population health science have something to do with big data, and we are now working with the big data folks to figure out how to have sort of a more clearly articulated message about those areas of overlap, et cetera. So the big data, so there's a great deal of interest both on the main campus and in the School of Medicine, and I would have to say stay tuned. I think there's we have a number of people who are computational scientists, biostatistics, bioinformatics, have some of the best around, and there's consideration of putting them together in a new department that is sort of related to this initiative, and I'm sure that'd be very interesting if it happened.
Other questions?
You mentioned a global health and ethics initiative. Can you say a little bit about that, what's included?
Well, that's part of Michelle Berry's center, and I haven't been directly involved in it, but they're looking at, they work broadly in both of these areas. We have a center for ethics, which is not just global, of course. An example of some recent kinds of things that have come up were Ebola and what you would do in terms of how treatment, vaccination, all the ethical issues around who gets these very scarce resources, et cetera. So it's those kinds of issues, and I wish I knew more about it, but those are the kinds of things.
Just to say, they have a very nice interactive program too, useful for students, and the case study is put up there, and you indicate how you would fit in, how you would respond, and get feedback on it.
Well, then, tomorrow, big game. Thanks very much, Jim.
UCSF is not participating in that. So, Doug, thanks very much for your nice presentation. You're gracious. Thanks. I want to clarify that really the person who pulled this all together is Devin McCabe, and I try to stay out of the way as much as possible. And I also want to thank Jay Sullivan, who's doing the audio-visual up there, and Lena Libatique, and a whole bunch of interns, students from Berkeley, who, again, it's kind of made it all happen logistically. We are at we're 2:30, a little bit ahead of schedule, amazingly enough. But I also I will recognize that the number of people here right now is slightly fewer than we anticipated for the workshop portion. So I think I want to do a quick poll, and if it seems advisable, we might combine a couple of workshops. So just as a reminder, the workshops are on Pursuing Global Health 2035, and we anticipated 4 workshops of financing issues with Dean Jameson and Stefan Vergey, costing with Gavin Yemi. Gavin, are you around at this point? So maybe not with Gavin, but Carol's here. And behavioral economics with Harsha Thirumurti and Jenny Liu, and then value of life years CEA and related issues on efficiency metrics with Naomi Byler, if I'm saying that right, Naomi, and myself. So let me get a quick show of hands of how many people intended to head to each of those sessions. And again, it might make sense to combine. So financing. Hands high. I can't really see anything. 1, 2. Okay. Costing. Costing is the leading one. Behavioral economics. Also a leading one. Your hands can go up only once, right, guys? And value of life years CEA and efficiency metrics. Also fewer. So maybe what we should do is combine into two workshops, one which will focus on behavioral economics, so definitely where there's a critical mass of hands there, and the other would combine financing, costing, and the other metrics. So any objections to that approach? Might be a little bit more efficient. All right, in that case, I think the rooms that we'll use for the financing, costing, value of life years will be, we'll go to, as it's indicated for costing, 1401. So Mission Hall, for those of you who are not oriented to our campus here at Mission Bay, Mission Hall means you go out into the main courtyard, hang a right, and go about, what is it, maybe 200 yards across one street. And that, I think, which is 3rd Ave, and that will bring you to a new building right there that's called Mission Hall, and the 1401 is on the entry level. And then behavioral economics is next to that in 1402, so we can actually all walk over there together, which I propose we do in about 10 minutes. So again, we'll have the 2 sessions, one on the financing, costing, and CA issues, and other on behavioral economics, and 1401 and 1402 Mission Hall. Can A group stay here? Yeah, we could do that. You know what? We can't do that. You know what? I just remember why we didn't put that in the schedule. We don't have the room after 4. What time, Devin?
Well, you could use N114.
You know, I think we should, Mission Hall, the rooms are a little better for this kind of thing. They can, N114 is kind of a...
That way we can all...
So Nancy, I think we all need to get a little exercise and stretch, so it's just 200 yards.
Sitting next to me and they disagree. They're not biased.
We can't, we have to be out of this room, and so we're going to have to move anyway, so why don't we just walk down the path. So we'll set out in about 5 minutes.